Recording in progress.
Good afternoon, everyone. We are pleased to welcome you back. So, Classic Cardio Academy International, in collaboration with JB Chemicals, welcome you all for the 6th online session of ECG Masterclass. This online educational training program is possible because of the educational grant by JB Chemicals and Pharmaceuticals. JB Chemicals is a maker of quality medicinal products like Silacar, Nicardia, Rantac, Metrogel, Bisotap, Dapacos, and many others. In today's agenda, we have three distinguished speakers. So first, Dr. Sadanan Shetty will speak on ECG in myocarditis, pericarditis, and COVID. In our second topic, Dr. Amaya Udyavar will speak on ECG in heart failure. And then Dr. V.T. Shah will speak on ECG during drug therapy. To tell you more about Classic Cardio Academy International, CCA is a platform to educate and share unbiased clinical scientific information on various topics of cardiology. They cover various topics like coronary and structural intervention procedures and supported by various experts from India and abroad. Objective of CCA is to raise the level of academic participation and bring the latest updates which are not covered on other platforms. The team members of CCA include, the founder member of CCA include Dr. V.T. Shah and Dr. Sadanan Shetty, while the National Advisory Board members include Dr. J.J. Dalal, Dr. Shirish Hiremat, Dr. Ajit Bhagwat, Dr. Siddharth Dagli, and Dr. Nitin Deshpande. CCA's Advisory Board international members include Dr. Nishit Choksi and Dr. Ramesh Dagubatti, while their Scientific Council of Advisors include Dr. Ashok Sheth, Dr. C. Manjunath, and Dr. Mulasari Ajit. So we have three eminent distinguished speakers today, Dr. V.T. Shah, Dr. Sadanan Shetty, and Dr. Amaya Udyavar. So before we start, let me give you a brief introduction about our today's eminent speakers. So our first distinguished speaker is Dr. V.T. Shah. Dr. Shah is trained in Germany in interventional cardiology. He has more than 30 years of clinical practice experience. He is ex-president of National Society of Preventing Heart Disease and Rehabilitation, NSPEAR. He is a co-founder of CCA International. He has published several publications in the reputed journals like Circulation, JACC, Heart, Indian Heart Journal, and other reputed journals. He specialized in IVIS, OCT, FFR, guided complex interventions, CTO and LM bifurcations, and primary angioplasties. He is a senior consultant interventional cardiologist at Global Hospital, Wokhart Hospital, Sefi Hospital, Breach Candy Hospital, Surana Setia Hospital, Raheja Fortis Hospital, and Prince Ali Khan Hospital. Our second distinguished speaker for today is Dr. Sadanan Shetty. Dr. Shetty was a professor at Dr. D.Y. Patil University School at Navi Mumbai. He's a director of Department of Cardiology, Somaya Super Specialty Institute in Mumbai. He's a CMD and founder at Sadanan Healthy Living Center in Mumbai. He's an editor-in-chief of Biography and Patient Education book. He's a founder at CVD International and CCA International. He's a president of Cardiology Society of India in Mumbai. He's a fellow of American College of Cardiology and European Society of Cardiology. He's a founder of Sadanan G2S2 Foundation, and he's an editor of Clinical Cases in Cardiology book, which was published in the year 2020. Our third speaker for today is Dr. Amaya Udyavar. Dr. Udyavar is currently a consultant cardiologist and electrophysiologist at PD Hinduja Hospital, Holy Family Hospital, Fortis Hospital, Karuna Hospital, Jagjeevan Ram Railway Hospital, and Jaslok Hospital. He has fellowship in cardiac devices and electrophysiology from Australia. He has fellowship in cardiac electrophysiology from Taiwan. He has published more than 40 publications in peer-reviewed national and international journals. He is well versed with the management of cardiac disorders, his specialty being cardiac electrophysiology. So we request our audience to please add your questions in the chat box. So now let me hand over the session to our first eminent speaker, Dr. Sadanan Shetty. Dr. Shetty will speak on ECG in myocarditis, pericarditis, and COVID. So over to you, Dr. Shetty.
You can see my slide.
Yes, sir.
Thank
Slides are
you.
visible.
Thank you, Vaibhav, and thank you, JB Chemicals and Pharma, for giving us this very unique opportunity. As you all know, friends, this is the 6th ECG masterclass session, and today we have included some of the, the very practical the ECG requirement in our day-to-day practice. And what I'm going to do is to tell you about ECG in myocarditis, pericarditis, and in the COVID current the pandemic we know. And Dr. Amaya Udyavar is going to touch upon how are the ECG finding in heart failure. And then finally, Dr. Vita is going to talk on how the ECG changes with the therapy, the drug therapy, both the cardiovascular drug and the non-cardiovascular drugs. Myocarditis, which basically, if you see here in healthy heart, the myocardium, as you see here, is very clean. Whereas in a myocarditis, you see the inflammation. We know that is the endocardium, is a myocardium, and this is the, the pericardial, which is the covering the heart. And if you look at here, this looks, reddish, inflamed. So basically, inflammation of the myocardium in simple term is called as a myocarditis, and which has got, wide range of clinical presentation. Some are very devastating, can give rise to like acute heart failure, cardiogenic shock, etc. And then there are certain which are which are mild in nature, usually manifest in otherwise healthy person, variety of infectious agents, autoimmune disorders and exogenous agents. Acute phase normally lasts for 0 to 2 weeks, and the effect is direct toxicity, cytotoxicity, and the cell-mediated cytotoxin in the cardiac muscle, and the chronic phase basically in autoimmune. So 50% of the time it is a idiopathic. Some of the viruses, enterovirus, Coxsackie virus, adeno, etc. Bacterial commonly due to streptococcus, tuberculosis, etc. Fungi, aspergillosis, candida, protozoal, drugs like anthracycline, cocaine, rheumatic fever, autoimmune disorders. I just want to brush upon just some of this salient point, not going into detail because our emphasis is more on the ECG and the correlation. Clinical presentation commonly like a flu-like symptoms, typically like arthralgia, malaise, fever. This also holds true for the COVID presentation. Most of the viral we know are presenting like a flu-like syndrome. They may have pharyngitis, tonsillitis, some upper respiratory tract infection like symptomatology, chest pain, sweat, dyspnea, palpitation when there is involvement, little more than the mild. And then of course, very severe myocarditis, heart failure, cardiogenic shock, syncope, or even sudden cardiac death can occur due to the AV block or a ventricular arrhythmia. So why we are discussing this topic? Because of this, the serious complication of this particular problem. Normally, diagnostic workup covers blood count, ESR, CRP, rheumatological screening if you're suspecting rheumatological disease, and in the cardiac biomarker like troponin I or T, and this is what we do in a COVID situation. Whenever a patient comes with a flu-like symptoms, we do this particular workup just to rule out, myocardial involvement. Viral antibody titers rarely indicated, but in some situation we carry out. ECG is normally non-specific, like a sinus tachycardia, STD changes, AV blocks. I will show you in my subsequent slides. And then, of course, the echocardiography can give us exact idea regarding the left ventricular function and also to rule out other causes. Today, After the ECG, clinical detail, X-ray chest, echocardiography becomes a very, very basic evaluation for a myocarditis. Of course, ECG is very, very rarely, like even in a situation like a COVID, when we have ST elevation, could be due to myocarditis, but we are not sure, like, what we call as a mimic. ECG can mimic myocarditis, myocardial infarction, Takasubo, etc. But we want to rule out CAD. So maybe angiography in a select case. MRI, lead GD, the gadolinium enhancement, again to see the inflammation, extracellular edema. All these are more important in some of the autoimmune or the nature of what type of myocarditis, like a giant cell myocarditis, etc. Even EMB, there's a myocardial biopsy is done. This is just to cover up the topic, but actually speaking, the ECG changes in myocarditis is just simple sinus tachycardia. And then non-specific STT changes. The sinus tachycardia is an important finding in the ECG, and this is disproportionate to the rise of fever. That means patient may not have much fever. We know that every degree centigrade increase 10 is the increase in heart rate. When there's a disproportionate increase in the heart rate, inappropriate for the temperature, then we suspect possibly there may be some myocardial dysfunction or a pericardial disease, or for that matter endocardial disease. All three layers of the muscle, like endocardium, myocardium, the pericardium, can give rise to sinus tachycardia to start with. But when we have some changes like a non-specific STT changes, then it could be an indicator of myocarditis. And other findings which are not common are prolonged QRS duration. QT prolongation is very important. Diffuse T-wave inversion, ventricular arrhythmia, AV conduction defects, inflammation of the adjacent pericardium, and therefore something like a myopericardium. Remember, all these changes can occur even in the COVID situation, because that again is more like a viral-like picture. And you see the prolonged QRS, QT prolongation. We'll discuss during the COVID topic. But essentially, when you talk about the non-specific ST segment changes, as you see here, the T wave is inverted here, ST is little sagging, like if you see here. So basically, ST changes are one of the findings for favoring myocarditis. In the first session, I told you, whenever you have a STT change, there are only 6 diagnoses. We have to keep it in mind. 6 diagnoses means common condition. One is a ischemic heart disease. Second thing is hypertrophy, that is a strain pattern. Third is a conduction disturbances. Fourth is the drug effect. Fifth is the electrolyte, and the last is a non-specific. So if you see here again, the non-specific STT changes, can be one of the important finding in favor of a myocarditis. Of course, we have got the clinical history, we have got the clinical examination, and then we go beyond that, looking into the ECG. So STT changes, one of the things is, is important in case of myocarditis. And we also know that along with the myocardial pathology, since the pericardium is very close, we can get into something like a myopericarditis. You can get an ST elevation, as you see here inferiorly, clear-cut ST elevation. So given patient who has myocarditis to start with, and subsequently when patient gets into hypercarditis, the ECG finding can clearly show, as you see here, ST elevation here. Only thing is that in AVR, the ST is depressed. There is a PR segment elevation as against ER. Of course, the pericarditis ECG I'm going to show separately, but remember, sinus tachycardia disproportionate to the fever or the level of temperature, we have to suspect either endocardial, myocardial, pericardial. And today we are discussing about the myocardial and the pericardial, endocardial, basically endocarditis and all. So these are the things we have to keep it in mind, after going through the history examinations. Treatment standard, when patient goes into heart failure, unloading drugs we normally give, avoiding physical exertion, particularly several months, very immunosuppression, sometime, immunological problem, like, giant cell myocarditis, SL rheumatoid arthritis. Otherwise, most of the time it is a self-limiting, but it can also give rise to myocardial dysfunction and then, cardiomyopathy like picture. And that is what we see in a COVID situation now. Of course, follow-up is required. Chronic inflammation may cause DCM, there's a cardiomyopathy dilated, and subsequent heart failure. And these are the few things what you should know when you talk about the myocarditis. And many patients recover, and many patients may have some residual cardiac dysfunction. Yeah. So prognosis normally depends upon the infecting agent and also what was the acute picture during the myocarditis. Is it a very fulminant, given next to heart failure, cardiogenic shock? Then possibly, it is a sinister course. Nearly 30% of myocarditis get dilated cardiomyopathy. 90% of patients, giant cell myocarditis, die or undergo transplant in 6 months. So giant cell myocarditis is one area which we can diagnose only by, beyond MRI, by doing the endomyocardial biopsy, etc. Now look at the, this is the LD pericardium as you see here. And if you see here pericarditis, as in myocarditis, we get the inflammation of the pericardium. So pericardium get thickened, there is inflammation, and all the debris, etc., can get collect. And therefore, what symptoms you get is a chest pain, not like an angina, like any chest pain which aggravates on movement, bending forward, taking a deep breath, something like a pleural pain is also typically like a pericarditis pain. So it is localized sharp pain, stabbing pain, increasing on deep breathing or changing the position of the body. And just like, the pleural pain, pericarditis has got a similar picture, and they can have a friction rub, and the ECG changes. First ECG may not show. So we do need serial ECG changes. Like in myocarditis, pericarditis also, you need a serial change. These are typical pain, what I described. Clinical presentation is more or less similar to the one like myocarditis, fever, dyspnea, tachypnea. This again can, differentiate myocarditis, pericarditis, cardiac tamponade, difficult to differentiate, but we fall back on echo, etc. Today, with the advent of transthoracic echo availability, it's very easy to diagnose these problems. Cough, of course, dysphagia, and pericardial inflammation cause infusion, like a myocarditis can give us to myopericarditis. Pericarditis can give us to myocarditis, like a perimyocarditis, because they are close to each other. Myocardium plus pericardium close to each other. Causes more or less go similar fashion, but one other thing we have to keep it in the tuberculosis among the bacterial causes, inflammatory cause, metabolic, etc. They're just to complete the list. Diagnostic workup, again, ECG, chest X-ray will show enlarged, particularly the base is narrow, but the other borders left and the right are enlarged. When you get an effusion at least more than 250, with a transthoracic echo, effusion is easy to diagnose. Of course, CT can show us calcification of the pericardium, particularly when you're suspecting.
Sir, you are on mute. Sir, you are on mute. Hello, sir, Dr. Shetty. Sir, you are on mute. Can we just tell sir that he is on mute?
I'll phone you.
Yeah.
Can we reach him and find out?
Yeah, somebody called him. I think he's on call. Dear delegates, there is some technical disturbance. Dr. Shetty will connect soon.
Some arrow problem with the arrow. We'll be sorting it out.
Yeah.
Yeah. It
Okay.
should be.
Now it came.
Yes, sir. So you're audible now. Yes, sir.
You can hear me?
Yes, sir. Yes, sir.
Yeah, sorry, because that arrow is a problem. Yeah, this is the typical X-ray what we see. Very narrow base and wide both the right and the left border. And this fluid can shift when you take in the lying down position. The base can become little widened. And this is a typical, like a bottleneck, what we call as in case
PPT is not displayed.
Huh?
PowerPoint is not displayed.
PowerPoint is not displayed.
No, sir, it's visible. You can just
No.
play it in the slideshow mode. Slideshow mode.
Slideshow.
Yeah, but now it is not sure.
So it's visible, but it's not on the slideshow mode. So you can just
Slideshow mode. Yeah.
slideshow. Yes, sir.
No, slideshow. You are not able to see, no? Are you able to see?
No, we are not able to see. I think
not able to see.
your title slide is seen.
I will just stop sharing and then I will again come back once again.
Yeah.
Let me just see again, yeah. Now you can see.
Yeah, now we can see the X-ray.
Yeah, okay, fine. Now I'm going further, yeah, now you can see. Okay. You can hear me, isn't the leads? Except for lead AVR and lead V1, plus or minus V1. But at least in AVR, definitely is the opposite reciprocal changes of concave ST elevation. We have showed earlier during our earlier presentation in the past, concave ST elevation is typical for pericarditis, convex is typical for STEMI, like that is a myocardial infarction. So when you have a concave ST elevation and PR depression throughout most of the limb lead, that lead 1, 2, 3, AVL, AVF, not AVR, and the precordial lead V2 to V6, whereas the reciprocal ST depression and PR elevation in lead AVR definitely plus or minus in V1. Again, sinus tachycardia is also common, like what you get in myocarditis, which I made a mention. And when you have a sinus tachycardia too much, patient has more, like a symptom of breathlessness, or then possibly we'll have to suspect pericardial effusion. And that time, the echocardiography will be of use to us. And this is what I wanted to show, that the ST is like concave, typical, unlike infarct where you have a convex one. And then if you see the PR, which is segment is down, when you draw a line from the P wave, end of P wave, to the beginning of the ST, the T wave beginning, that is the end of the ST here, and you see here, this is the PR which is down, that means the depressed, whereas here the ST is elevated in all the leads except for AVR, which is exactly opposite, that is ST is depressed and the AVR is elevated. This is almost sine qua non of the pericarditis and the sign of pericardial involvement, the ECG wise. Like if you see here, acute pericarditis, typically ST elevation here, ST elevation here. If you look at here, ST is depressed here. And if you see the PR again is slightly looking up actually. So ST elevation in say lateral lead, inferolateral lead, and you see the ST depression AVR like in here. If you see again here, ST elevation, inferolateral lead, AVR showing ST depression, PR slight elevation here, and you see V1 also showing ST depression, PR elevation. So here both in V1 and AVR it is showing again like a pericarditis. Pericarditis, one more ECG clear cut. If you see here ST depression more clear, whereas V1 is not showing that much ST depression, whereas ST elevation lead 1, 2, the AVL, V4 to V6, V3 to V6. So multiple leads in inferolateral leads is so all leads showing ST elevation concave, PR segment down, and in AVR ST depression down, PR segment elevation. These are the characteristic feature of the ECG finding of pericarditis. If you look here, acute myopericarditis, like as I mentioned earlier, pericarditis pathology can have a myocardial component, or a myocardium can give rise to pericardial component. Here again, ST elevation, very clear cut off, like a pericardial pathology. Sinus tachycardia is there. There are some T wave changes in some leads. So these are, like a typical of an acute myopericarditis. And today, with the advent of imaging, particularly the echo, etc., the life becomes much easier for, the making a correct diagnosis. The treatment depends upon the cause, but generally, NSAID drugs, colchicine in a recurrent pericarditis, steroid, pericardiosynthesis, etc. This again is not the topic of our discussion. I just wanted to complete the sort of, the topic. Surgical therapy, whenever there is, recurrent large effusion or pericardial window to create, to drain, and then pericardectomy when you have got a constitutive pericarditis. One of the complications is the constitutive pericarditis, particularly in a tuberculous one, and there, there is a pericardial inflammation, calcification, restricted cardiac filling, something like a restrictive heart failure, and then of course the cardiac tamponade. Whenever any patient with pericarditis becomes breathless, hypotensive, and tachycardic, and that like he has feature like a elevated JVP, pulses paradoxes, then we have to suspect cardiac tamponade always. And cardiac tamponade, we will have a low voltage ECG, or we can have the QRS alternance. We can have alternate QRS of different morphology, marked tachycardia, maybe the axis deviation, etc., can occur. And this is a typical with the advent of echocardiography. We can make a easy diagnosis. We can also see the RV free wall is collapsed, whether there is a septal abnormality. These are all echo finding, but this is a way we can diagnose the pericardial complication like cardiac tamponade. Let me address now COVID-19. In COVID-19, what I discussed, myocarditis, pericarditis can also affect can be affected even in COVID disease. So COVID, one of the presentation could be myocarditis or a pericarditis. Now let us look into which are the other cardiovascular problems which can occur in COVID situation. The high risk of infection. Who are the high risk population? Elderly people, men, pregnant individual, people with the underlying condition. Like if patient has a premorbid hypertension, cardiovascular disease, coronary artery disease, diabetes, COPD, they have already their like their morbid illness can make the COVID more worse. Even the premorbid condition can get worsened, and on the top of that, COVID-related complication can increase the problem. So high risk population, we have a high risk of mortality, and these are due to the direct cytopathic effect of the virus, cytokine storm, sustained inflammatory response, hypoxia, septic shock. So population with a high risk of infection is also at high risk of development of severe disease and mortality. So we need to remember that, because both the premorbid illness and the severe COVID can give rise to increased mortality, patient going into critical condition, cardiogenic shock, etc. Now, what are the cardiovascular, the emergency we get in COVID pandemic? Now, number of challenges. Now, one of the things is between this COVID and the cardiovascular disease, what are they? I will talk to you. Response to CVD, the COVID-19 can compromise the rapid triage of the non-COVID-19 patients with the cardiovascular condition. The problem, as we all know, in the beginning of COVID, like last year, around March, April, that we had a difficulty in making a diagnosis or treating a non-COVID patient because of this COVID pandemic. And that, again, we have to remember, acute cardiac injury like raised troponin level can occur in 1 in 5 patients who are hospitalized for COVID-19. And it is a poor marker of, the prognosis. And we know that the troponin can rise due to myocardial pathology, can rise in myocarditis, myocardial infarction, etc. But that is again one thing we have to keep it in mind in a COVID situation. Now, what are the interaction between the cardiovascular disease and the COVID situation? We know the COVID is a direct viral infection, commonly respiratory, because they get into respiratory tract, acute respiratory distress syndrome, systemic inflammation, and then multiple the pathophysiology we know about it. And then of course the COVID-19 drugs, whatever we use, that also could have a cardiovascular side effects. Of course, Dr. Vitisha is going to address that issue also. What are the cardiovascular drug can have effect, or what are the COVID drugs, or what drugs we use during COVID can affect the cardiovascular system, like particularly QT prolongation, etc. Now, cardiovascular disease was underlying comorbidity. I mentioned to you what are the cardiovascular complications, particularly in COVID? One is the acute cardiac injury. There's a myocardial pathology, troponin goes up, like myocarditis, direct infection, acute coronary syndrome. Like non-COVID, during COVID, patient can have presentation of an acute coronary syndrome, again are related to the COVID-19, and patient could be like, the same, the problem can go into heart failure. Then the arrhythmia, importantly, QT prolongation, VFib, VT, atrial flutter, atrial fibrillation, supraventricular tachycardia, and then thromboembolism, like a pulmonary embolism, stroke, etc. And the common cardiovascular drugs, which also could increase the severity of COVID. We know that ACE inhibitor, ARB, because the similarity in the COVID virus, so they can be into invasive. And then, like a thiazolidine drugs also could have some mention of increasing the severity of COVID. So essentially, remember, cardiac injury, myocarditis, acute coronary syndrome, arrhythmia, thromboembolisms can be there, due to the various cardiovascular disease can occur. And during COVID, when this occurs, this interaction bidirectional can have a bad prognosis. So basically, direct viral infection and the systemic inflammation, what all it can give rise to thromboembolism. And thromboembolism can occur anywhere, particularly the pulmonary embolism, stroke, etc. Incidence is 20%, mortality is 30%. Arrhythmia, like VTAC, supraventricular arrhythmia is more common. Then, of course, sinus bradycardia can occur, inappropriate sinus tachycardia can occur, AV block can occur, so on. About 44%. Myocardial infarction can occur, stroke can occur, almost the 3%, 40% mortality. And then, of course, a cardiac injury by raised troponin, so like a myocarditis, etc. So these are the various presentation what you can get during COVID infection. Now let us look at the different ECG during the COVID one. This is one case where 50-year-old patient with a sore throat and recent sick contact woke up short of breath with a throat tightness. If you see here, the heart rate is very fast. Saturation is a little borderline. Respiratory is okay. Patient has the blood pressure a little high. And if you see, it definitely left atrial enlargement, could be due to the long-standing hypertension. And then we also see a biphasic T wave, and there may be S3, ST elevation. So this is an abnormal ECG. What is the real diagnosis at this time? Difficult to diagnose. Maybe a serial ECG, etc. So definitely there is a left atrial enlargement, non-specific T wave abnormality is an abnormal ECG. We have to look at the patients, the progress day to day based on the oxygen saturation, based on the ECG finding. But we have to keep all the possibility. What are the possibilities? We'll have to keep it in mind. I will mention in the subsequent slide. Another patient, 70-year-old patient, the 2 weeks of dry cough, shortness of breath, and the syncope. BP is about 120, heart rate is 110, saturation on the borderline. If you see, definitely distinctly tachycardic, and typical changes like what we see, like an LAD lesion, where you biphasic or the symmetrical T wave inversion from V1 to V4, and also you see tiny depression in V1, lead 1 and lead AVL. So this is definitely more like something like an NSTEMI, but we have to keep it in mind, not by one ECG alone, we can make a diagnosis. Maybe we'll have to look into other markers, biomarkers like a TROPI, patient's clinical symptomatology, and maybe serial ECG can give us idea. And in a doubtful situation, we can do the echocardiography and we can get the region wall motion abnormality. This patient, 40-year-old patient, shortness of breath, chest tightness, again, saturation normal, BP about 140/80. If you look at here, ECG nearly looks normal, But if you look at the ECG, which was taken earlier, same patient, you see the changes are here, like a basic T wave like here. And this is typically what we see sometimes. If you see here again, like a Takasubo or a ST elevation can occur like in a non-obstructive, but something a stress cardiomyopathy. That also is common in a patient of like a typical infarct pattern, like you see here. Infarct part could be Takasubo or even coronary heart disease. Again, we have to look into the echo whether it is a localized wall motion abnormality related to the particular artery involvement, or is it global, or is it like a typical apical ballooning, and things like that. And some situations we may do the imaging before taking the patient for a coronary angiogram, like a CT coronary, etc. Or you may do the invasive angiogram and rule out the obstructive versus non-obstructive disease. 65-year-old patient, 1 week of intermittent epigastric pain, shortness of breath, currently in pain 5 hours. And if you look at here, the non-specific STT abnormality, like this could be again, the abnormality in which you can get occur in COVID, and here you have a bradycardia, even the sinus bradycardia, sinus pauses, sick sinus syndrome, AV nodal block also has been described in case of COVID. So we have to keep all this in mind. And if you look at lead 3, it is typical, like something like a biphasic T, and we have to keep a possibility of infarct, myocarditis, etc. 30-year-old patient with a 5 days of fever and cough, increasing shortness of breath. If you look at here, like we have the rightward axis, very important, non-specific STT abnormality, abnormal ECG, but importantly tachycardia, and the rightward axis. And if patient has a shortness of breath, one other possibility we'll have to keep it in mind is a pulmonary embolism, because already the axis is rightward, and we have this type of abnormality, STT abnormality, sinus tachycardia, right axis deviation, and this could be an indicator of PE. And then we have to see the serial ECG. We have to look at saturation is already down with 4 liter. So definitely this patient is a little bit on the hypoxic side. So therefore we have to keep a thromboembolic involvement involving the pulmonary arteries. Look here, 45-year-old patient, 1 week of fever, cough, increasing shortness of breath. And if you look at here, voltage criteria, like if you see deep this one, and this patient, as a voltage criteria was LVH, T-wave abnormality you see very clearly here. And this is something like a left atrial enlargement is there. We have to see whether this is a part of, something like, the development of myocarditis or myocardial involvement, like, even the ischemic heart disease for that matter. Patient is a young patient. So we have to keep all this possibility. We'll have to go for the focus. There's a point of care ultrasonography. There's a transthoracic echocardiogram. We'll have to look into multiple biomarkers also, and then we have to go about it. ECG demonstrating sinus tachycardia and low voltage and a non-specific changes in this. If you look at here, we see this is something like, what we see is the septal infarct. One other thing I forgot to mention, many times ECG we have to take in a prone position in a patient of a COVID. When we take the ECG, 12-lead ECG, particularly the septal V1 to V6, in the supine versus the prone position, we could have changes of the ECG different. Like if you see here, it is something like a R wave, which is actually mirror image of what you get in a septal of a Q wave in here. So this is the posteriorly the taken prone position ECG, whereas here if you see the ST depressions are seen, but this initial vectors, the like what we see in the posterior wall MI, when you take the posterior lead, we see the reciprocal changes. So V1, V2 are showing reciprocal changes, since the V1, V2 is put in the back of the patient, prone position ECG. And if you look at this here, in the course of time, this particular changes settles. And if you look at the anterior, typically, when patient improves, you take a supine ECG and you see typically you see like something like a QS pattern restricted to V1 to V3, V4, again suggesting of the infarct pattern like any other time. This patient has again the like a QS pattern, like something like infarct. This is a old case. He has a pre-morbid illness already, and on the top of that COVID, very morbid COVID, and that can affect both like a tachycardia, like a old infarct pattern, marked TV changes, etc. And this patient is hypoxic, needs a very aggressive therapy. This is ECG what is taken at the time of admission. In the course of time, it is taken, again showing little bradycardia here. Here there is some evidence of AV block is here. And again, as the recovery occurs, patient goes back to something like here. So this, when you take a serial ECG, we can see in a same given patient what all changes can occur. So whenever you have ST elevation cardiac in the ECG, in a case of COVID or in the COVID situation, if the COVID is positive or probable, symptoms consistent with the MI, ECG consistent with the MI, that means the changes are restricted to one particular arterial pattern. Then we do the focus. There's a point of care ultrasonography. There's a echocardiography to confirm the wall motion abnormality. And if it is typically in a particular vascular territory, it is a STEMI. and therefore this particular patient requires a primary PCI. Now, if it is a possible COVID, and if symptoms are considered MI, ECG considered MI, again STEMI, and can go into primary PCI. Equivocal symptoms, atypical ECG, repeat the ECG, maybe echocardiography to detect the wall motion abnormality, serial ECG, portable X-ray, consider COVID-19, myocarditis, and then of course the emergency department, and then the ICU joint decision regarding coronary CT angiogram, or the activating the cardiac cath lab, and then accordingly making a call. So at times we can do the CT coronary before taking of the patient for angiogram, but again CT coronary imaging, we have to take care of all the precautions, of the COVID situation, and that is one of the the protection of the level 2, level 3 protection, what we do in a situation of primary PCI. So we have to be cautious, minimum members in the lab, etc. Now, so when you got an acute myocardial infarction during COVID, there is a study which tells us that not necessarily all patients have a COVID positive. Like there is one study of almost 187 patients of myocardial infarction during the COVID-19 outbreak. And when they done the angiogram, NSTEMI is seen about 76 patients, 40%, 60% STEMI. But in that also, COVID negative is more, 84%. COVID positive just 12%. So also in a STEMI, COVID negative is 91. Again, the COVID positive just in the 20%, the 18%. So telling us that the pre-morbid illness can get aggravated during COVID, means the presentation could be during the COVID outbreak, but not necessarily due to COVID, maybe the stress factor, etc. So here again, outcome will depend upon TIMI score, Gray score, what is the ejection fraction, cardiac biomarkers, and then we put all this into multivariate analysis, and these are the different intermediate predictors of the in-hospital death. But again, we have to remember that we have to treat COVID negative NSTEMI and COVID negative STEMI just like what we were doing before the pandemic of COVID. Another area, imaging, as I mentioned in the previous slide, imaging is done like cardiac imaging, like a CT coronary imaging we do before taking for a regular the coronary angiogram in an ambiguous situation, like as I mentioned, Takasawa cardiomyopathy or ST changes are not very clear cut and things like that, then we can make use of cardiac imaging. But you have to be cautious, the lab, the precautions for all the, to see that the infection, no cross infection, etc. So suspected COVID-19, unstable patient, acute coronary, takes into cath lab, PCI, COVID diagnosis may non-COVID, remains in ICU, COVID ICU. If it's a non-ACS situation, we have to see, the admit and then evaluation. If it's a COVID diagnosis, goes into that. If it is not, then we can go to non-COVID. Stable patient can be discharged with a COVID diagnosis if you are admitting either inpatient positive or negative COVID. And then, of course, the cardiovascular evaluation, clinical ECG. Remember, not one examination or one clinical markers are not enough. We have to keep on doing serially. And therefore, the eye-sensitive troponin, like normally in a coronary, rise and fall, whereas in a patient of, something like a myocarditis, it remains for a long time, continuously. There's no rise and fall immediately, like what we see in a coronary artery disease. So before treatment of a patient in a COVID patient with, cardiovascular suspicion, clinical history, treating the modified risk factors, list of all the drugs, the measuring the QT interval 12-lead ECG, electrolytes, renal, liver function, and of course the device or telemetry for monitoring, important. And this particular thing also, mobile device and the telemetry, has come up with more use during COVID time because of, non-contact of the patient. So this becomes easy. So low risk patient who has no heart disease or mild symptoms, QTC less than 460 milliseconds, no restriction for treatment. And then, we can be a new QTC measurement after 3 days if patient is admitted. Interval and very high risk like QTC more than 500 seconds. Consider treatment, repeat QTC every 2 to 4 hours to see that patient doesn't get the further QT prolongation. And this is the way we have to go into. Now, whenever we have got the QTC management is very important. Maybe Dr. VT Shah will take up that issue, because the drug and QTC outcome is very important even during COVID time, how the QTC is measured and QTC. The other area what we are looking into in a COVID, the imaging like echocardiography. I told you whether it is normal or increased LV wall, myocarditis, or a dilated LV with impaired function, dilated cardiomyopathy, or regional wall motion abnormality due to myocardial infarction, myocarditis, stress cardiomyopathy. Remember, in all three or in all these things, ST elevation will be there. ST elevation can be there in myocarditis, can be in cardiomyopathy, can be in myocardial infarction, can be in pulmonary embolism, but we have to fall back on the other investigations. And this is what is the another algorithm where adults with known or suspected COVID without the pre-existing COVID. When patient don't have the pre-existing disease, we have to go by usual our history taking. We have to evaluate by history taking, examination, then investing like a troponin. We have to do the NT-pro and BNP whenever patient breathless. Serial ECGs are important, and then of course the doing a 2D echocardiography and doing the monitoring in the ICU or the telemeter or the the Android monitoring, and then the clear diagnosis. Okay, is it an ACS, arrhythmia, cardiac shock, cardiomyopathy, heart failure, myocarditis, pericarditis, pericardial effusion, or high clinical suspicion but without the diagnosis, repeating all the investigation. So at one time you can't stamp a diagnosis, but you want to repeat a history examination. This is what again is another way of suspicion of ST segment elevation, the ECG, severe non-cardiac illness with a low predicted benefit from the invasive angiography. So just a medical management. If high clinical suspicion for acute coronary occlusion and the patient likely to get benefit from revascularization is the STEMI, that is your PAMI. And here again, in between uncertainty, we have to wait and watch, maybe CCTA, that's doing a CT coronary angiogram, and then depending upon that coronary. Early intubation initiation of mechanical ventilation is important in ICU or emergency department if there is evidence of respiratory failure, or when you have a patient who's hypoxic or taken for invasive procedure, because intubation or even the initiation of mechanical ventilation in the cath lab when patient becomes bad is difficult. So intubate, put the patient on mechanical ventilation and then take the patient to the lab. So just to summarize, last slide, that patient with a cardiovascular emergency during COVID pandemic, we have to see that non-COVID emergencies. Because of the COVID pandemic, we are scared of non-COVID emergency also, and that's what happened in the beginning of the COVID in March, April, all over the our country as well as internationally. Even acute intervention like PAMI was not done. Many international situations, invasive therapy was done because of the fear of COVID, which is gradually changing. And today, our non-COVID emergencies during COVID pandemic, we are doing with less level of protection. Unlike in the very beginning, we used to be level 3 protection. But like yesterday, when I was discussing during our another meeting, many cath lab, they are doing the non-COVID emergencies, with the usual our precaution like any other intervention. And of course, the point of care ECG and the 2D echocardiography, like a point of care sonogram for PE, acute coronary occlusion. And for a sick COVID-19 patient, consider cardiovascular complication, arrhythmia, myocarditis, heart failure. We should pick up early and we have to treat accordingly. And for admitted ACS patient, COVID-19 testing helps cardiologists plan their intervention. As a matter of fact, when we take up the patient for ACS today, along with our routine evaluation, like all those virus examination, HIV, hepatitis B, hepatitis C, creatinine, hemoglobin, etc., doing an RT-PCR or doing the CT to exclude the pulmonary involvement is more or less common today, particularly when patient is going for a surgical procedure. We do the HRCT to see there is no lung involvement, etc. With this, I would end the topic, and I would request Amaya to have his presentation.
Yeah. I just share my screen.
Yeah. Yeah.
So hello everyone. I hope everybody can see and hear.
Yeah, yeah.
So the topic given to me today is ECG in heart failure. As we all know, heart failure is a very common clinical condition, and diagnosing it by ECG in some cases may give you initial clues. If there is no history of heart failure, one can suspect that there is something wrong with the heart. So I'll be discussing some few examples of ECGs which may give us some clues regarding heart failure. Now, this one is a ECG of a patient. And if you see the ECG, the first thing which strikes you is that there is some sinus tachycardia. So if you see sinus tachycardia, that means there is definitely either it's a sinus tachycardia which is just normal, or it could be some abnormal physiology or pathology. So the thing about this ECG is if you see the limb leads, that is limb lead 1, 2, 3, AVR, AVL, AVF, you will notice that the QRS complexes are low voltage. While if you see the chest leads, lead V1, V2, V3, and V4, V5, V6, you will see that the precordial leads are having a high voltage QRS complexes. Not only that, if you see from V1 to V5, in fact, there is no R wave at all. The R wave starts appearing in the lead V5. So this is called as poor progression of R wave in the precordial leads. Normally, you will see a transition zone, which is in lead V3 or V4. Here, in fact, only in V5 the R wave appears. That also is tiny. And V6 actually the R wave appears. So if you see, there are three things: low limb lead voltage, high precordial lead voltage, and poor progression of R wave in precordial leads. So this is an triad which is called and described by Goldberger many years back, and it is called Goldberger's ECG triad in heart failure. High precordial QRS voltage. This is defined as S in V1 or V2 plus R in V5, V6. If it's more than 3.5, it's a high voltage. While if you have a low limb voltage, which is the total QRS amplitude in each, that is R plus S. If you add in each of the limb leads, it's less than 8 millivolts and 0.8 millivolts. And poor R wave progression, that is the transition is almost in V4, V5, 6. So this is a highly specific change for heart failure. So if you ask me, can ECG predict LV systolic dysfunction? And ECG, in the studies at least, it has shown that it has a sensitivity of 90%, while the specificity is actually low, almost 45% in predicting LV systolic heart function. And in some patients, a normal ECG, you can definitely rule out a LV systolic dysfunction of EF less than 30% with a normal ECG. Because if you have EF less than 30, definitely you are going to find some changes. So ECG as a first step is very good for at least screening for LV systolic heart function. And more so in the elderly. In the young age group, you may not have so many clues, but in the elderly, you will definitely have a lot of clues. Now see this ECG, it's actually a Holter, which was done in one of the patients. And the first thing which strikes you is in the Holter, in the initial 3 leads, lead 1, 2, 3, you will see that there is a, I'll just find it. I'll just point it. So here you see there's a Q wave in lead 2 and 3, which is quite deep. So it's an abnormal Q wave. So it is evidence of an old infarction. The other thing which you observe is there is a RR irregularity in one of the leads, which is suggestive of an atrial fibrillation. And the other thing which you notice is a LBBB, left bundle branch block morphology. So if you see these either in combination or even single, this might be a patient who may have LV systolic dysfunction. So what are the changes in ECG heart failure? Q waves, which are suggestive of an old infarction. Left bundle branch block pattern, again suggestive of a damaged myocardium. ST depression or abnormal T waves. Hypertrophy, because LV hypertrophy patients may land in what is called as heart failure with preserved ejection fraction, which is called diastolic heart failure. And atrial fibrillation or flutter, which is normally seen. Most of these changes either or may be seen in almost 77% of the patients with reduced ejection heart function in the elderly. So low voltage, as we all know, when you have low voltage, it means that there's not much of viable myocardium. It also means that the cardiac chambers are enlarged. So this is definitely one of the markers for an heart failure. Of course, one needs to rule out other causes of low voltage like a COPD or emphysema chest or severe obesity, which can also cause low voltage on the ECG. So discrepancy, as we just discussed, between the extremity and the precordial leads indicates a cardiac enlargement. ST segment depression, which is persistent ST segment elevation or persistent T wave inversion. These are again a marker of poor paradoxical wall motion. What about the QRS width? Longer the QRS width, it means there is lesser synchrony or lesser synchrony between the chambers or an electrical dyssynchrony. So that means the electrical system is diseased. And that's why the longer the QRS, poorer the LV function and poorer the prognosis. When you have a QRS wide, you can have most of the time bundle branch brown, which is one of the causes, either a massive scar in those patients, which can cause a delayed conduction from cell to cell, hypertrophy and dilatation, normally seen in patients with hypertrophic cardiomyopathy. So these are the reasons for a QRS width. If you see one of these studies with West study analysis showed that if your QRS keeps on increasing, and if you have a QRS which is more than 220, in fact, you have a directly proportional mortality increase. So the survival, if you see, these are the survival graphs, which was in patients with NYHA class 2 and 3 and 4. 3,600 patients ECGs were scanned, and they found that the relative risk of widest QRS was 5 times greater than the patient with the narrowest QRS. So this is a marker of sudden cardiac death, not only that, also of heart failure. Again, another study which showed that if you have a QRS width which is more than 160, the mortality rate in 36 months duration is almost as high as 58%. Now, what is the difference between these two ECGs? If you notice, this is the first ECG which is marked as C, and the second ECG is after 15 days marked as D. You will notice that the first ECG, the limb leads are narrow or shorter, not narrow, shorter in amplitude, while in the second ECG, the limb leads, the QRS voltage is taller. Same with the precordial. So you see an increase in the voltage. Now, why is this? There is normally, as we know, peripheral edema, which can cause attenuated ECG voltage. So this causes a decreased amplitude of the QRS complexes, the P wave, shortened duration of the QRS complexes and QT intervals. And when you give a diuretic and you alleviate the peripheral edema, these changes on the ECG also get reversed. And that is what you are seeing here. The changes of low voltage QRSs are reversed. This is nothing but basically chest wall edema, sometimes causing the attenuation of the QRS changes or the P wave amplitude. And this is reversed when you give a dose of diuretic. Not only it points to a diagnosis, it also may give clues to a probable etiology. Now, in this ECG, you will see that this patient has a right atrial dilatation. You have a tall P waves in lead 2. You have a negative terminal complex in lead V1 and an RV hypertrophy in lead V1. So, as we know in MBBS days, this is pointing to a classical ECG of severe mitral stenosis, which is seen in this patient, where you have a left atrial enlargement and then back pressure causing RV hypertrophy and right atrial enlargement. Now, what about this ECG? You will see that in this ECG also, you have a deep negative terminal component of the P wave, okay? And there is a widened, say, slightly widened QRS. There's also a peaked P wave. These are all suggestive of for all 4 chamber enlargement. Now, LVH, as we all know, the criteria is if the S wave in is more than V2, more than 35, which you see here, the S wave from lead V2, negative wave, is almost more than 35 millimeters. And there's a dominance of S wave from V1 to V4. This is then criteria for saying LV hypertrophy. If you have a right axis deviation, which is also present in this patient, which is suggestive of associated right ventricular hypertrophy. So that means there's a biventricular hypertrophy. And of course, you have a negative deep component in the left atrium and the peaked P waves, which are more than 2.5 of the right atrium. So it suggests a right atrium hypertrophy and left atrium and right atrium hypertrophy. So all 4 chambers are enlarged. This again gives a clue that there must be some amount of dilatation. What about this ECG? What's unusual about this ECG? You have a left bundle branch block pattern. So you have a LBVB. And if you see, there's a right axis division. Normally, LBVB associated with normal axis or left axis. But here you see AVR is almost flat. And that's why it is like a right axis division. This 3 is positive. So this is a highly specific change for dilated cardiomyopathy. Again, another ECG showing the first thing which strikes you about is the P wave, very low amplitude. Not only that, if you see the ECG in the QRSs, you see the QRS amplitude, even in V5, V6, you don't have a good R wave. And S wave also are shallow, it's not very deep. So overall, a very low voltage QRS. Okay. So when you have a low voltage QRS, it could most probably be an cardiomyopathy, which could be end stage. And it can also be a storage disorder, like glycogen storage disorder or amyloidosis. And it could be a manifestation of hypothyroidism. So a low voltage ECG gives you a clue of what could be the reason of this patient. Again, you have another patient with a low voltage QRS, but here you observe Q waves. You see a Q wave in lead 2, you see a Q wave in lead 3, you see a Q wave in lead AVF. Not only that, you see the lateral leads, sorry, V1 to V4, there's a splintered QRS with a Q wave. Again, manifestation of a infarction. So this is nothing but infarcted changes. You have a biphasic T wave with slight ST coving, suggestive of. So here the low voltage is all because of dead myocardium or non-viable myocardium, post myocardial infarction state. So when you have a Q wave, again here another patient, you see V1 to V6. There's no Q wave at all. In fact, there's only QS pattern. Not only that, in the anterior leads, you also see in the inferior leads, lead 2, 3, AVF. There's a total QS pattern. Again, suggesting that there's a loss of Q wave, so loss of R wave. So this is again suggestive of a QS pattern, and that's why suggestive of a loss of functioning myocardium. And if you see the extent, it is present in almost V1 to V6, and is also present in the inferior leads. So infarct, which is not only involving the anterior wall, but also the inferior wall. So this patient will definitely have a low ejection fraction. The other change you will see, because the myocardium is deceased, the cell-to-cell conduction in the myocardium is slow. So this causes what is called a wide QRS or a splintered QRS. So you see in lead 3, you have splintered QRS, almost like a W pattern. And here also in lead 2, you have a splintered QRS. A splintered QRS means that the cell-to-cell conduction is slow. This could either be because of an infarcted or a fibrosed heart, which is suggestive of scarring in the myocardium. So patchy scar, as I said, and again diseased fascicles. So if you have fascicles which are diseased, that also can give rise to a splintered QRS. What about this patient? This patient has suffered MI a few months back, but if you see the ECG even now, you have a persistent ST elevation. The STs have still not resolved. This is highly suggestive of an aneurysm formation. So again, a clue to suggest that this patient may also have a low ejection fraction. And of course, arrhythmias. So if you come to arrhythmias, atrial fibrillation is one of the commonest arrhythmias which you see with patients with LV dysfunction, and a broad QRS because of left bundle branch block pattern. So when you have a slowing of conduction in the myocardium, you will have a intraventricular conduction delay, or you may have a left bundle branch block pattern because of damage to the left bundle. Again, when the bundles are damaged, it could involve either left bundle or, as in this ECG, a right bundle with a left anterior hemiblock. Again, suggestive of not only the right bundle is damaged, but also the left anterior fascicle is also damaged, causing a left anterior hemiblock. So again, suggestive a large infarction which is involving the right side as well as the left side of the septum. Now, those are the changes in heart failure. Now, we all know heart failure, one of the reasons why patient die is also sudden cardiac arrest. In heart failure, there are only two causes when the patient expires. One is repeated episodes of heart failure, giving rise to cardiogenic shock or very poor cardiac output and causing cardiogenic shock. The second cause is a sudden cardiac death. Now, this is also equally common in patients with heart failure, and it is not very nicely diagnosed or not given adequate attention by the physicians and the cardiologists. But is also almost 50% of the patients in heart failure, especially class 4, will die suddenly, and this is called as sudden cardiac arrest. Now, if you see, there are novel predictors, and one of the simple tools to use to predict a patient of sudden cardiac arrest or sudden cardiac death is a resting ECG. So there's something called as a cumulative electrical risk. Here, cumulative electrical risk, just by taking and measuring some things on the ECG. The European Heart Journal, there was this study where they measured almost 6 parameters. The first parameter was a heart rate, which is more than 75, QRS transition, which is late, as we already discussed in the previous ECGs, LV hypertrophy, and a frontal QRS axis, which is more than 90 degrees, a prolonged QT interval, and a T peak to T of end. So if this interval is more than 90, that means basically a prolonged duration of the T wave. Again, if it's more than the peak to end of the T interval is more than 90 milliseconds, these 6 parameters were taken and there was a score which was given. This is called as electrical risk score. And this improved the risk stratification for sudden cardiac death. So if you see patients who had these parameters, when you have a heart rate more than 75, increased QRS duration, prolonged QT, T peak to T end of more than 90, a QRS angle of T wave and QRS angle more than 90, delayed QRS transition, LV hypertrophy, and intrinsic odds deflection. These are all suggestive of increased odds ratio. And if you have more than 4 parameters in a single patient, it increased, this is a follow-up of almost 14 years, it increased the sudden cardiac incidence as much as 6.6%. So that was observed in this study. Of course, you can also have other parameters which can give some information on these patients. So this is one beautiful paper where they had a patient with reduced ejection fraction and preserved ejection fraction. So the second column is a preserved ejection fraction, and the third column is reduced ejection fraction. And the fourth column is a Holter, or sorry, ECG. So if you see what prognostic value these parameters contain, so these are ECG derived risk stratifiers which had prognostic value in different clinical conditions. So if you see, the plus denotes that these have prognostic implication, while the negative or the question mark means either it's a negative or there's still no data convincingly to suggest that it has prognostic value. So here, a resting heart rate, increased resting heart rate, of course, has prognostic value. Heart rate variability has prognostic value. Heart rate turbulence, of course, these are measured by different equipment like Holter or different, say, machines. Intra-Atrial conduction delay. So this is easily measured by seeing a broad P wave. So intra-atrial conduction delay, again, has prognostic value in almost all patients. Atrial dilatation, atrial fibrillation, again, prognostic implication. Site of AV block. So if you have a higher, lower AV block site, it is having more prognostic value. In the QRS, as we all discussed, increased width of the QRS, left bundle branch block pattern, notching or fractionated QRS. Q waves, again suggestive of infarcted, reduced limb voltage, LV hypertrophy, and an increased QRS to T wave angulation, LV hypertrophy, signal average ECG, which measures what is called as late potentials in the ECG. About QT interval, increased QT interval, not only that, there's something called as QT dispersion, which can also have some value, and ST elevation or depression. So if you have elevation or depression on the ECG, it might have some value. T wave. So if you have a changing T wave axis, which is called as T wave alternance, or an increased T wave amplitude in some patients like V1 and AVR, these can also have prognostic value. Ventricular ectopy, depending on where its width and what is its site of origin. So if you have a ventricular ectopics, it's an inferior wall MI, and the patient has ventricular ectopics which are coming from the inferior wall, it might have some prognostic value. Coupling intervals. If the coupling interval between the native QRS and the VPC is short, that means a shorter coupling interval again has prognostic value. Frequent ventricular beats, which increase during exercise. And of course, non-sustained VT and sustained VT. So these are all the ECG markers which normally will give you some prognostic value on sudden cardiac arrest. Now, of course, these all are not applied in clinical practice because currently the guidelines only recommend that we apply marker of LV ejection fraction for sudden cardiac death stratification. So I think I'll end here with my lecture. I'll hand over the mic to my senior colleague, Dr. VT Shah, for the next lecture.
Thanks, Amay, for those illustrative examples which you showed us.
Thanks.
It was quite interesting even for us to learn more about how to interpret ECG and get some clue from ECG as to what could be the underlying condition. So my topic today, I have just a second. Let me see what's happening here. 1 second, it's coming. Yeah, here it is. And so I have slightly modified my title. Okay, so please excuse me for that, so that it's a bit more interesting. Effect of drugs on ECG. So I have slightly modified for the simple reason to make you understand. Okay, now why this is not going ahead? I think I'll have to stop share and then come back. What's the problem? Okay, now can you see?
No, not yet.
No. Sorry. I think so somewhere down the line I got, how is that? I can't escape. Just a second. Sorry. Something gone. I just disconnect myself.
Dear delegates, there is some technical problem. So Dr. VT Shah will be back within a minute. So he's trying to rectify the technical issue. So he will be back in 1 minute.
In the meanwhile, if you want, we can answer one query if we have one.
Yeah, any questions in the chat box, Vaibhav?
Okay, fine. Yeah. So we can take up a few questions till Dr.
Yeah,
Vitisha
yeah.
joins in. Yeah. So
Yeah,
we
yeah,
have,
yeah.
yeah. So we have a question from Dr. Pritesh Pawar from Solapur. The question is COVID is COVID myocarditis pathologically viral myocarditis or immune myocarditis or a combination of both?
Amaya, you want to address that?
Yeah. So if you see whatever studies have been published, in fact, there is a varying numbers, but especially when it comes to what is called a cytokine storm, that is when you see it in patients with severe COVID infection. So in cytokine storm, it is more of a immunological reaction against the virus. And that's why it is more of autoimmune myocarditis in those patients. So if you see actual myocardial cell invasion by the virus has been seen only in 5 to 7% of the cases. So at least the studies, initial studies which have shown post-mortem studies where they try to isolate the virus, they found that active myocarditis, where the cell wall was invaded by the virus, was only seen in 5 to 7%. So active myocarditis must be a little rare compared to the autoimmune myocarditis.
VT, you are ready? Then we can pick up, or VT, are you ready? Or yeah, Vaibhav, you can take one.
Okay.
Yeah, sorry. So I'm back. Can I
Yeah.
start?
Okay,
Sure.
okay.
Yes, sir.
Okay, start. Yeah. Yeah, we can see.
Yeah, but now let me see what's happening here. Okay. Why can I not see my share screen button? Yeah, now I can see. Yeah, now is it visible?
It is visible. Yeah, now correct. You carry on.
Okay, thank you. So sorry for that. So the use of various medications, especially for prolonged period, is associated with characteristic changes on the ECG. The possibility of drug-induced ECG changes giving rise to symptoms like palpitation, syncope, presyncope, giddiness, chest heaviness should also be borne in mind. These changes may occur with either therapeutic or toxic blood levels of the drugs, not necessarily toxic blood levels. These drugs could be cardiac or non-cardiac drugs or regular drugs which the general practitioners and physicians use in their practice. ECG changes could be misinterpreted for ischemic heart disease, VTAC, and so on. So that's what Dr. Sada also showed, that mimics of ischemic heart. So knowing the previous drug history is very important when an ECG is recorded. Just to recapitulate the whole thing, the conduction system of the heart, the sinoatrial node. One sec. Now let me get this pointer options. Yeah. So the sinoatrial node, the internodal arteries, the AV node, bundle of His, the left bundle, right bundle, and the Purkinje fibers. So this is the classic ECG during the contraction of the myocardium. That is a single cell, the P wave, the QR, ST, and these are the various segments which you all know about. But what I want you to revise is that this is the membrane potential. When a myocardial cell contracts, so this is the phase of depolarization, rapid repolarization, steady, and then gradual, and this is phase 4 again. So depending upon this is your waveform of contraction, the QRS and the T wave till the end of repolarization. So this is the QT interval which Dr. Amaya was showing you. This is the QRS, the phase of contraction. So you have drugs which can, So coming to this, So this is sodium influx. This is potassium, you see here, the calcium influx and the sodium potassium ATP channels. So these are all the different channels on which the drugs can act and thereby delay the contraction or the relaxation, and depending upon that, they can show you changes on the ECG. Now, what are they? Sodium channel blockers, slow calcium channel blockers, outward potassium channel blockers, and sodium potassium ATPase blockers. Okay. Now, let us look at the sodium channel blockers. We will not discuss much about this because basically these are all cardiac drugs written by cardiologists and they would be aware of what to look for. But more important, today I am going to stress upon the drugs which you use regularly and might face such an abnormality. Psychiatric drugs like carbamazepine, cyclic antidepressant, neuroleptics, antipsychotics, amantadine, diphenhydramine, antihistaminics, chloroquine during these COVID times, orphanadrine, narcotic pain relievers, cocaine abuse. Quinine, of course, is less used nowadays, but once upon a time we had quinine compounds for VPCs. Now, this I showed you the various channels which we have. Now, what could be the ECG changes because of these so-called sodium channel blockers? QRS widening, a right bundle branch block pattern, R wave elevation in AVR lead, that is the reciprocal, rightward axis deviation, sometimes VTVF, sometimes bradycardia and asystole, and STT changes in cocaine toxicity. Now see this. This is with amitriptyline. Okay. So when you give these antidepressant drugs and psychotic drugs to these patients, sometimes during their suicidal tendencies or by mistake, voluntary, involuntary, they might take 10 or 20 tablets of these drugs. These patients' normal ECG, you can see the PQRST, you can see the waveforms, the amplitude, the QT interval, the QRS, everything. Compare with this when he comes with so-called poisoning, right? Sinus tachycardia, you can see here, 148 per minute. The QRS now is wide, 0.12 millisecond. You can see the QRS wide. You can see the QRS widening here. The R wave elevation in AVR. The QT prolongation, if you see here, see this, right from here to here, almost going into the second wave. So QT prolongation and a right axis deviation. All these are features to say that, yes, this is this patient. So ask the drug history. Sometimes they may come for the first time to you and you may be not their primary physician. And you may see this ECG. You might mistake this for a cardiomyopathy also, because there are so many features, QT, the QRS, and sinus tachycardia. So drug history is very important. Coming to the second, calcium channel blockers. Nifedipine, you all know, causes tachycardia. Amlodipine may cause tachycardia. But what about verapamil or diltiazem, other calcium channel blockers? What they can? They regularly cause bradycardia. Because that's why sometimes you prefer a diltiazem or a verapamil for a hypertensive patient, or to control the heart rate in an atrial fibrillation patient. And then they can give rise to varying degrees of AV block because they suppress the AV node. And if it is too much, they can cause junctional rhythm, occasionally an asystole or wide QRS STT changes. Now, one extreme example of such verapamil toxicity or poisoning you can see here. See first the normal ECG, okay, and see this, bradycardia 41, minor right bundle branch block, but see the QT prolongation right from here right up to again here, prolonged QT prolongation. See the ST segment, the J point depression, see the type of STs which are going up, and see the T wave broadening. All these features of verapamil toxicity. Don't mistake this for an acute infarct or an acute event. Take the history of the patient. What about potassium channel blockers, outward potassium channel blockers? As I said, don't concentrate on the so-called cardiac drugs, but look at the other drugs. Okay, the psychiatry drugs, antidepressant, the psychotics, the phenothiazine drugs, the antihistaminics, the macrolides, the quinolones like ciprofloxacin, moxie, sparfloxacin, macrolides, erythromycin, chloroquine. So many commonly used drugs which can cause ECG side effects or ECG changes and sometimes can give rise to catastrophe. You should pay attention when you give these drugs to this patient, especially if they say one episode of giddiness, one episode of falling down, then everything is fine, occasional palpitations. So many patients which you give quinolones come with premature ventricular beats. That is a sign possibly this is due to the quinolones which you are giving. So QT prolongation, T or U wave abnormalities, multiple PVCs. In extreme example, torsades can happen. Okay, so let's see that. Now see here. I showed you this graph, depolarization and repolarization. So depolarization normal, and then see the slow repolarization, broadening, right? See the long QT interval, see this red mark over here. How it is reflected on the ECG, see this. This is the normal QT interval and this is your prolonged QT interval. So it is like a long hand going outstretched. So when you see this, immediately it should struck you, oh, the QT. And beware that by and large in today's world, please get a computerized ECG machine which can quickly pick up all these intervals and tell you whether they are normal, abnormal, or at least tell you that this is the QT interval roughly what it is into milliseconds. It makes your job very easy. Once you see that, it should immediately strike you. Have you given this patient a quinolone? Have you given this patient erythromycin, clarithromycin, and so on in today's days? Then you give them quinine, you give them chloroquine for COVID. Says, although now it is off the list, but it was once upon a time recommended by the task force committee. So there are so many drugs. And then what happens, I have seen prescriptions of antihistaminic, erythromycin, and quinolones all added together in one, a broad spectrum treatment. Gram positive, gram negative, antihistaminics, and so on, along with chloroquine, because you suspect COVID also. All these drugs, mind well, is a perfect cocktail for all this QT prolongation. And in extreme example, see these torsades. Saw that patient going into a torsades phenomenon and collapsing down. Okay, so this is again the same thing. Now, these are the causes. Of course, electrolyte imbalances also are there. We'll come to that later on. Thyroid dysfunction can cause, and the other causes of drugs, as I showed you, are here. So please remember, I'm not going to say this, antimicrobials, levofloxacin, cipro, gatifloxin, moxie, then macrolides, clarithrol, erythro, antifungal, ketoconazole, itraconazole, very commonly used antifungal drugs. Antidepressant, of course, I told you, amitriptyline, imipramine, doxepin, fluoxetine, sertraline, and venlafaxine. Antipsychotics, haloperidol, and all those drugs and others. Please remember, prokinetics. People are used to giving lisapride and so on for all the gastroesophageal reflux. Cisapride is one of them, which was initially, now of course less used, but still people use it. So cisapride also is one which can give QT prolongation and TDP. And mind well that these may not be perfectly normal patients. You may think he is perfectly normal, but they could be cardiac patients themselves and coming to you for the first time without giving you a history that I'm already on cardiac drugs. Or sometimes in a known cardiac patient, you prescribe it in your busy practice without realizing that this could have interaction with the drugs which he is already taking. And maybe he is already taking Cardaron for atrial fibrillation or for VTAC or VPCs. So sumatriptan also, these drugs, anti-migraine drugs, and arsenic, of course, we don't use nowadays. So these are the drugs commonly used in your practice which can give rise to. See this example of ciprofloxacin. ECG, look at the prolonged QT interval. Now, if you were to take an action potential rhythm, you can see this magnified, so-called small ST evaluation here, and see the prolonged QT interval. Of course, this is magnified, this is 0.5, this is 10. Now, other 30 minutes after giving an IV preparation, again, same thing. So this can happen, especially when you are giving for prolonged periods, or you are giving to a cardiac patient who is already on some cardiac drugs, or you are giving multiple drugs which have the same effect. He may be a patient of depression where he's already taking antidepressant, and you give all this masala so-called, and sometimes the patient can land into problems. So this is again an example of a long QT interval giving rise to torsades. And so now this patient, after discontinuation, they can come back. Now this is Cardaron toxicity, of course. So many physicians are in the habit of giving IV Cardaron for more than, let's say, for more than the emergency, for 6 hours or 24 hours at the max, and then you should switch over to oral. And without noting the QT interval, very important. Please daily take ECG when these patients are on Cardaron, at least in the initial phase when you are loading them. Take the QT interval. As soon as you see bradycardia and a prolonged QT, please stop temporarily or reduce the dose. Otherwise, they may go in torsades and you might have to shock them for this rather than anything. Okay, antihistaminic, QT prolongation, diphenhydramine. Now, it looks very innocuous. If you see here, you will hardly see anything. But if you have the computerized QT intervals, then you will pick up this very minimal so-called, see this in V6, see the QT interval, how prolonged slightly it is. It looks as if it is a bit more stretched. That's where your suspicion should be. So then you go on continuing antihistaminic without knowing that, and you land up in this so-called Brugada syndrome. See those waves here, right? See this here, the prolonged QT, the notched here, the R wave in V1, and these T waves, inversions. So these are the drugs. Now, what about sodium potassium ATPase? The classic example is Digitalis. Digitalis was used quite commonly in olden days for all valvular lesions and all heart failure lesions. Nowadays, of course, it is restricted. So the Digitalis blocks this sodium potassium ATPase and increases the inotropy. But at the same time, it has a lot of side effects also. If you don't monitor the blood levels of this, so it can be flutter, VTAC, VFib, multiple ventricular extrasystoles, and so on. Now, the other common thing is electrolyte imbalance. Electrolyte imbalance because of drugs, hypokalemia. Commonest we see is diuretics. And what would you see this? Or in septicemia, so many septic infections also, you would see hypokalemia. Now, flattening or inversion of the T wave, increased prominence of the U wave, depression of ST segment. More important is when it comes to the stage of multiple premature VPCs and then VTACs. So you have to be very careful. And lastly, heart rate prolongation. So this is patient with hypokalemia. You can see the U waves here in a 53-year-old man receiving diuretic therapy. The patient's potassium is 1.7. QT is prolonged and the U waves are over here. So you can see right from here up to here. So these are all prolonged QT intervals, and this is case of hypokalemia. One has to treat this and monitor the potassium level. What about hyperkalemia? Now, this is an ECG of a 42-year-old with acute renal failure. But in practice, I would say that, of course, this could be in the ICU setup with potassium of 7.1. And you can see here quite prominent big T waves or biphasic T waves, and a patient going into bradycardia later on. And then, yeah, so this is with 7.8 with bundle branch block, the P wave disappearing, and the patient can go into VTAC also or heart blocks also in this situation. So then the serum potassium after dialysis is 4.5, and you can see now how the ECG behaves, although there are still VPCs over here with gradually over a period of time would disappear. So hyperkalemia in clinical situation, you should be careful when you are giving this. The commonest drugs which general practitioners and physicians give in their day-to-day practice is the ARBs for hypertension. Because these are the most safest, they don't have cough, unlike ACE inhibitors. So they feel that you just give them this commonly used telmisartan ARB, and then things would be okay without any monitoring. Sometime you will land up in hyperkalemia, especially elderly population, especially those patients who have eGFRs low or so-called CKD. You may not know them. A diabetic patient who has got urinary tract infection, or who may have pyelonephritis, or who may have chronic renal disease or glomerular sclerosis, so many things. History of kidney stones in young individuals. So it could be many. So at least monitor once a potassium level when you give ARBs to patients so that they don't land up in hyperkalemia. Once again, along with this, people are used to taking, say, so-called fruit juices, coconut water, almonds and dry fruits, and everything adds. The other drugs are aldactone or spironolactone, drugs which are MRAs, mineral receptor antagonist, and eplerenone and aldactone. They can give rise to high potassium levels along with the ARBs when we give in heart failure patients. So these are the situations where you have to be. The other drugs, the other electrolyte is hypocalcemia and hypercalcemia. You have to be careful about this also, because this is also not so uncommon situation. And this is one such example of hypocalcemia. This is, of course, a CKD patient with hypocalcemia. And if you see here, again, prolonged QT interval, T-wave inversions. So when you record an ECG for such patients, please take the history of the patient. What drugs is he on? What are the underlying conditions? This is hyperparathyroidism with calcium levels of more than 15. And you can see the shortened QT interval. You see this interval from here to here. You see this interval, narrow QT interval. So these are, and hypercalcemia is more common when the patient is on malignant, anti-malignant drugs. I have seen these calls of hypercalcemia during our ICU calls or in hospitals when patients are on anti-malignant drugs. Anti-arrhythmic drugs, of course, now I would not like you to go into detail, but showing you some of these. See this prolonged QT with ST depression. This is with quinidine, procanamide, and disopyramide. Once upon a time, quinidine was very commonly used, then came disopyramide, but of course now it's less commonly used, and markedly prolonged QT interval till the end of T waves. And this is somewhat early repolarization pattern, which is there, which can happen with lidocaine and mexiletine. Flecainamide, I would not discuss this in detail with you, because these are all antiarrhythmic drugs which we would use them and follow them commonly. But enough to suffice to say, this is one example of diltiazem. You can see a blocked P wave over here. Saw that? So these are, here you can see how there is sinus bradycardia. And then if you prolong it, then you have these blocked P waves. So when you have such kind of, you should always remember that there could be drugs which can, this is digitalis. If you see here, the ST depression and the T waves, flattened T waves, and this is the so-called hockey stick, or which is known as the mustache sign, the Camelot's mustache sign over here, digitalis. And this is the extreme form where you see a sort of bidirectional VT, you know, clinically. So hardly anything, multiple VPCs, alternance, and so on. So this is Digitalis effect. Beta blockers, of course, again, sinus bradycardia or nodal bradycardia. This is Torsades with sotalol, which is also beta blocker, but a class 3 antiarrhythmic drug. Methyl dopa, aldomet, which is used in pregnancy and hypertension. That you have to remember that time. Clonidine and imidazoline derivatives. This clonidine, of course, is an antihypertensive. Reserpine nowadays not used. Prazosin and other alpha blockers can also cause this first degree AV blocks and bradyarrhythmias. This is with macrolide antibiotics, that is erythromycin and the clarithromycin, which are being used. So prolonged QT interval and ST intervals and depressed ST segment. Prolonged QT, depressed ST segment, and then see the tall T waves going and the R waves followed by the T waves over here. So this could be because of that. Penicillin anaphylaxis, this is example. So this is also, of course, most of them don't use it nowadays in their outpatient department, but once upon a time, this was quite common to give penicillin. And you can see here during the hypotensive episode, see the sinus tachycardia, see the narrow QRS, and then you give him adrenaline, then this is because of that you give Xylocard also, and then after adrenaline injection you can see the normal QRS. So you treat this by steroids and adrenaline, the anaphylaxis. Of course, this is treatment of drug substance for the cardiologist. I would not expand on that, but in summary, I would say the use of various medication is associated with characteristic changes on ECG. These changes may occur with either therapeutic or toxic blood levels. ECG is a valuable source of information in poisoned patients, especially drug poisoning, and has the potential to enhance and direct their care. Many drugs with no overt cardiovascular effects from therapeutic dosing, as I gave you all the examples of routinely used drugs, become cardiotoxic in overdose or prolonged dose. And I would add, in those cardiac patients whom you give them as an additional drug without knowing the drug interaction of those drugs. Knowledge of this drug pharmacokinetics, pharmacodynamics, and the adverse drug effects profile is a mandatory thing before you prescribe them. Many blocker drugs that affect all the channels, other being Ecgs, so they may act through the autonomic nervous system, the sympathetic or the parasympathetic. Drug abuse also one of them. So ECG should be examined extremely early in initial evaluation of most patients on drugs, coming with some cardiovascular manifestation or without, but especially when on prolonged use. Thank you very much for that, and I'll stop sharing now.
Yeah, it was excellent, VT. Only one point to add in hypocalcemia, the QT prolongation is due to the prolonged ST segment. So this is one, unlike the in a QT normally in all those electrolyte, etc.
Right.
To some extent is a misnomer, It is appearing an inversion of the U wave, which makes, like a QU wave. Actually, to tell you, it's not a QT actually, it's a QU interval, because, U wave becomes very prominent and all, The ST segment prolonged in case of hypocalcemia with hyperkalemia. This is very sinister, sort of, sine cone of, CKD setting, where calcium is low on one side and the potassium is high on the other side, Now, meanwhile, Vaibhav, if you got any questions, you can this. And for the delegates, importantly, what Dr. Vitisha highlighted, drug history, but, for the many physicians who are busy in their practice, drug history becomes very, very, difficult to take in, your detailed history. And the important is to also see whether the patient is in, cardiovascular disease, harboring cardiovascular disease. Like many times, the drug may be toxic, like we are using amiodarone, we are using sotalol, but then we are careful of using that, like we measure QT interval regularly. it is very easy to say, don't use that, don't use, like an antidepressant is one area where, the drug, it has to be used. But to me, some of the antibiotics are out. I don't use any more quinolones at all. I don't use macrolide antibiotic at all. In fact, this CDC, US and all, I think 2-3 years ago, already, almost in US and all, I don't think macrolide antibiotics are any more used. And if you have to see what antibacterial spectrum of the macrolide, something great, at the most the atypical organisms. Gram-positive, you have got a lot of drugs, and the atypical organism can be easily taken care of with the doxycycline. And doxycycline is one, is both oral and parenteral available. And that is one use which can, make use of all these atypical and, whatever atypical pneumonia or typical, mycoplasma, legionella, those type of thing where macrolide antibiotics are preferred. So at least in my pen, I don't know, Amaya also want to comment, at least last 2-3 years of time, ever since we know about this QT prolongation, I don't use macrolide at all. And I don't use...
Dr. Shetty, the thing is, you see, COVID times, the use of these macrolides have been rampant, I would say.
I agree with you.
Because see, pneumonia pattern, immediately they would add a macrolide along with the routine cephalosporins.
I know that is what, that is why VT, I was just mentioning for the physician to know a particular antibiotic selection on the spectrum on what it works. What is the likely spectrum you're, inhibiting by this antibiotic? This is the point. Only problem about the doxycycline is orally it may be irritant in the acute situation, but luckily, few companies are making parenteral, and so possibly in an admitted patient. I agree with you. There are some situations where we are forced to use antibiotic, forced to use cardiac drug like all the anti-arrhythmic drugs, etc. But then we have to know that, that how to carefully use those drugs, So your point is very well taken in your summarizing slide, that we have to be very, very careful of drug history, and then, any cardiac disease, prior cardiac disease. And the other important thing, one thing is the renal function, urine output and all. Both magnesium and potassium, are basically, your urine output. If you've got any degree of CKD, like as you mentioned rightly, we are using Arbs, we are using ACE inhibitor. Now we are using ARNI, we are using MRAs. We have to be very careful, and it's very clearly written. If the potassium is more than 5, creatinine roughly 1.8 or so, they are more or less contraindicated. And particularly in heart failure, when you have to use multiple drugs which retain potassium, and also borderline CKD, because cardiorenal syndrome coexisting, it becomes very, very difficult for us to give the therapy. And that's a therapeutic, problem. But, unknowingly giving a drug, particularly the antihistaminic, is another area where we have to be also very, very careful. Vaibhav, you can have this thing, or your question on antibiotic, like, macrolide, quinolones,
Normally, clinically what I have observed is that these torsades, extremely common, and normally you will see in post-op situations where the surgeons have done a gallbladder surgery or an appendix surgery, and normally in these surgeries they prefer a quinolone. Correct. So they will give a quinolone, and they will also add some antiemetic like emisate or Cardaron, and plus already these patients may be on a beta blocker for blood pressure control, and they are most of the time elderly ladies, 70 plus, and their body weight is hardly 40 kilos or 50 kilos, and that is when we see this QT prolongation, and extremely common. And I think because of this combination, what happens, a torsade is created, and these patients are nil by mouth, and that's why they are having hypokalemia. So actually a very good milieu for getting torsades.
No, actually it's all combination, so-called masala treatment and the milieu and everything together comes out. So many times, as you rightly said, in a post-operative situation, you find this and suddenly you get a call that such and such patient has got VTAC, VFib, we have shocked him, and now please look for ischemic heart.
So the advice is that at least when you have any cardiac, say gastrosurgery or any surgery for that matter, see whether the patient is having a cardiac etiology or cardiac problem. If there's a cardiac problem, then see what medications they are taking, and at least monitor the QT interval. As Dr. Vitisha said, that on the electronic ECG machine, see what is the QT. So you get some clues that the QTC is normal. And do not give blindly emisset. I have seen a lot of patients, because they are admitted in the hospital, from day one, they are starting emisset or PAN-D. So this is a blindly common practice which should not be followed, because that are pro-arrhythmic drugs, especially long QT. Unless the patient has vomiting, then only you can. I have seen patients having a combination of PAN-D with emisset and cisapride.
Yes.
By gastroenterologists for their reflux acid disease.
Reflex.
These all three drugs prolong QT.
I agree with you, Amaya. More than the arrhythmia, even the use of proton pump inhibitor in ICU setting is the source of infection actually. Nosocomial infection. In fact, the two things what you should not be doing in ICU. One is the routine use of proton pump inhibitor, and second thing, the hand washing. These two things alone can prevent nosocomial or ICU acquired infection almost to the tune of 80%. There are good the papers on this particular thing. So nosocomial, you are reducing the acid secretion in the stomach by using proton pump inhibitor is bad. And I agree with you totally. The first thing we cut in ICU round is stop proton pump inhibitor and stop all those emisset business. Every ICU, I don't know from where it came, but we have to this one. The other thing you rightly mentioned about all these cardiac drugs, we are careful before giving the next dose. We say measure the QT, then give. The problem, as VT showed in his slides, that inadvertent use, without knowing only, you don't have a knowledge of the side effects, and you write a prescription, particularly the outdoor practice, it becomes very, very difficult. We in hospital, like a cardiac, specialty and intervention, we know that, when you're using a drip, measure the QT, and every 8 hourly, every 6 hourly, and then give the next dose. If it is an oral preparation, or cut down the dose and things like that. So this particular thing should go in the delegate's mind that we need to use drugs at times, but then how to use it, without getting into trouble. That's the thing, So one side is not to use at all few molecules, according to me, because those can be easily given by other drugs, like antibiotic, like, quinolone, or drug like, macrolide. I have got enough drug today, which has the same spectrum. That's one thing I would say. But when you have to use sotalol, when you have to use amiodarone, or maybe class 1 drugs, antiarrhythmic, we have to use that drugs. But then we use it, with a proper care. And that's another important thing, people should know. And acutely ill patient is toxic, is vomiting, and therefore, some degree of electrolyte abnormality. Unfortunately, as you said, toxicity and all, the patient goes into that. You can't give a massage for hours together, Hypokalemic, any cardiac pathology is a dangerous thing, Hyperkalemia, at least you give one calcium gluconate, or immediately something can be, come back to at least the myocardial component of all this hyperkalemia. Though the potassium will take time to come down, at least that is okay. But in hypokalemia is a problem, that, you can't give push, potassium, anything like that. And that is why it is very important for the delegate to know that hypokalemia at any time, and if he gets into toxicity or he gets into ventricular arrhythmia, will be very, very dangerous situation, because we don't get enough time to treat this. What do you say?
Yeah. So most important is to know the drug interactions.
Exactly, yeah.
Yeah, when you give so many multiple drugs in the ICU, one has to think of, and if you don't know anything, at least take a routine ECG daily.
Correct.
And monitor all the intervals. And that is why in all the trials of most of the drugs, maybe non-cardiac also, the trials will include QT interval. You look at the anti-diabetic drugs.
Yeah.
The QT intervals are measured. And when they are not randomized trials for many of these so-called drugs which are not on the FDA list or European sanctioned, but they are coming from other Asian countries, without any trial, we don't have any QT interval data of them, and we don't know what happens. And then all of a sudden, those drugs along with these other drugs, and you get a patient of torsades.
Absolutely. In fact, cardiac safety was whatever you mentioned. The major point is around QT. In fact, that's why even among the gliptin, even the teneligliptin to some extent is blamed.
You named it. I was reserving it.
Though it is not very well, documented all the time. But the point what you're saying is right. The cardiac safety QT means, like a hypoglycemia, for that matter, is a QT prolongation. And again, arrhythmia related to that, But the other important thing, Amaya, I always as a teach, cardiac cycle is 0.8 second and 0.4 second is a QT interval. Like I'm in a very, thumb rule I say, when you have a cardiac cycle of 0.8 second, where systole 0.3, diastole 0.5, and your QT is 0.4 second. So 0.8, half of the cardiac cycle is a QT, So at a rate of 100 is about 50, something like that. What I'm trying to say, half of that becomes something like a very user friendly in the bedside, like sometime QTC, etc. But it's important that QTC has to be done. It's not just QT prolongation; it should be corrected to the heart rate. As a matter of, we don't do for the other parameter, like a PR interval also get changed. All cardiac interval is going to change with the change in the heart rate, but we are not giving because PR interval, even prolonging it don't have too much of a significance, unlike a QT prolongation. That's why we all the time talk about QT. And for the delegates also should know QT interval is measured from the beginning of Q wave to the end of T wave. That's also very, very important, Many times, you may not have Q wave in a QRS, where this, then we take, probably the R to T wave, end of the T wave, but it's a QT interval, which is, from the beginning of ventricular repolarization to the end of repolarization. So half of cardiac cycle, 0.4 second, a cardiac cycle 0.8 is an easy way to, remember like that. And, these are the few important things. About the Digitalis, what VT said is very, very true, because Digitalis is again coming back, at least in heart failure with a bad LV function beta blocker. To minimize that, we are using only half dose now, like a half tablet of Digitalis. Isn't it, Amaya?
Yes.
Because, therefore, at least, the toxic effect, because we want to keep the Digitalis level a little on the lower side. And therefore, the maintenance dose is half tablet, and particularly when patient has a renal dysfunction, etc. Elderly people, heart failure patient, they already got, setting of a CKD or a cardiorenal problem. And on the top of that, we are using other heart failure therapy. So to reduce the Digitalis toxicity, because Digitalis is a useful drug, all of us, what do you say about it? Isn't it?
Yes, it is. It is useful, more for reserved for AF with heart failure.
Yeah, AF with heart failure. And, because particularly when patients are poor LV, maybe less than 20, 25 cutoff, when you're using, drugs, something positive, I know true. Right. So point is, if you're using it carefully with a half dose maintenance dose, probably all these, side effects of Digitalis can be, a little bit inhibited. The point what we are discussing now, where you have to use a drug, dangerous drugs, how to minimize, that way.
We'll take some
Other question, Vaibhav? VT, anything?
Because in the questions, we may be able to answer a lot of the queries.
Yeah, go ahead. Amaya, just read them out.
So question from Dr. Manoj Jagdale from Ahmednagar. Is there any role of steroids in myocarditis?
Yeah, Amaya, you can, there is a definite,
Yeah, so if you have granulomatous myocarditis, which is inflammatory myocarditis, so in those conditions where it is autoimmune, so there's this giant cell myocarditis. Now, this has to be diagnosed only by biopsy. So one needs to do an endomyocardial biopsy and see whether this is a giant cell myocarditis. So that is the condition where immunosuppressants, including steroids, methotrexate, azathioprine, these are given as treatment for this condition, and it is partially reversible. So if you have a patient who is very bad condition, not improving with your normal supportive care, if you see the guidelines, they recommend that you should do an endomyocardial biopsy and see whether this is one of these treatable myocarditis, and then give steroids if it's a giant cell myocarditis. The problem is that we don't do endomyocardial biopsy in most of these patients. Not only that, even the pathologists are not good enough to diagnose this giant cell myocarditis because they are not so familiar with cardiac biopsy specimens. And that's why most of these conditions probably get missed. So I think that is the only thing which can probably respond to steroids or immunosuppressants. Otherwise, viral myocarditis and other myocarditis, there are some studies where people have tried giving steroids, but I think there is still not convincing evidence to show that steroids help.
Yeah, next question, Vaibhav.
Yes, so question from Dr. Pritesh Pawar from Solapur. how to differentiate acute pericarditis ECG versus benign early repolarization ECG?
Yeah, that actually, it's a good question. Patient of an acute pericarditis basically is symptomatic, power, because they come with some symptoms. And what you are saying about the pericarditis, that ST elevation and that, the PR depression in the, like whatever, most of the lead except for AVR and V1. And if you see in AVR, as I showed clearly, which doesn't occur in early repolation. And the other important thing is what is called the J point. This thing, it's not like a concave ST elevation what you get in early repolation. That J point one, which makes a very clear difference. Anything to add, Amaya, or agree or?
Yeah, I agree, because normally benign, the early repolation is a benign condition, and it will be seen in a particular groups of leads like infero-lateral or lateral leads or inferior leads, while pericarditis, as you rightly said, is seen a global, so it is almost seen on all the leads, and plus symptomatic status. I think if you have these two, and PR depression, which is again a marker of that thing.
Plus, pericarditis would be having sinus tachycardia also.
Exactly, yeah. In fact, as the heart rate increases, it's a very important point what Dr. Vitisha mentioned. As a tachycardia, the early repolation goes away, like early repolation abnormality. One of the ways is to, like when you do the treadmill, many times to rule out ischemic heart disease, you do the treadmill, that changes totally disappear. Though now benign early repolation, no more benign, because there are 4 types. Like particularly when you got ST elevation in multiple leads, then probably it's got a bad this saying. There are reports of sudden cardiac death in BER also. There's a benign early repolarization. But anything increasing sympathetic activity will abolish that ST changes, which are typical of the early repolarization. So early repolarization patient, like usually the symptom, therefore history is very, very vital. History is vital. When you take a good history, then examine and then take the ECG, tachycardia, then ST elevation.
And you may take the help of echo finally.
Echo also, yeah. Because today, with the echo, we are much comfortable, whenever you are.
And correlate everything.
Correlate. We have to require, we, in fact, from the beginning of our ECG masterclass, we have been discussing no time ECG should be read isolation. Remember that. Like many times our junior may bring us and show the ECG or may send up on WhatsApp. That is, our level of this thing a little different, because our postgraduates or DNB residents fellow is seen and he just want to confirm or exclude 1 or 2 points. But for you as a delegate to understand is always clinical history first, then examination, then the extension of history examination is ECG, like that. And that's why, in fact, our postgraduate exam ECG is given to the candidate, because he has to make something like an extension of exam. Never read ECG, particularly in a difficult situation. Like this thing, early repolation pericarditis, you have to go to patient's history, story. We have to ask the patient what is the problem, etc. Even just a routine OPD patient having these changes, many times we tell our resident, this is a benign early repolation, because we have not taken the history, but our junior have taken and given us the feedback. So never see ECG in isolation. The teaching is that we have to treat patient, not treat the ECG. So always history, examination, making some working plan, then the ECG. Agree with it?
Yeah, definitely.
Yeah, next.
Yes, the next question, what is signal?
Just before answering, a very important, because you can have a normal ECG in acute chest pain, mind you. Early repolation, even if you miss it, is fine. We see time and again, chest pain, clinical examination, nothing much, and ECG normal. After a few hours, you may have a frank infarct. So history is so important in here, very, very important. In a coronary artery disease particularly, we should not miss, because that very important time of the symptom presentation, patient comes to the hospital, but we miss the thing. Many times we do see it. The disease is missed, next day patient come to us, by that time patient is an established MI. If you go to the history, it's a typical of an MI. So always give importance to history, particularly in acute chest pain, and whenever you're in doubt, overdo, I don't care, maybe take one more ECG after 1 hour, 2 hours, or you observe for some time, but don't miss acute MI. Acute MI, is very, very important, and don't depend just on normal ECG. It's very, very important. Yeah. Next.
Yes. So next question: what is signal averaged ECG? Where should we use it?
Yeah, Amaya, you can say that for this.
So signal average ECG is basically a special type of ECG. So what happens is the ECG is basically magnified. The QRS amplitude of the ECG is magnified almost like 400 times. And at the end of the QRS, you measure what is called as deflections. And these are called as late potentials because they occur after the QRS. So if you have a big QRS and then you have small fragmented deflections. So these deflections are measured. So these are very small deflections which normal ECGs will not pick up. The signal average ECGs will pick up. These deflections, then you measure the amplitude and the duration. So if the amplitude is big and if the duration is long, that means there is some slowing down of the conduction in the ventricles. Now, when you have a slowing down of the conduction, that means the QR is broader than what we normally feel. If you feel that the QR is 120 on the normal ECG, when you take a signal average ECG, you may find that the QRS is 120, but the late potential are another 40 milliseconds. So ideally here the QRS is 120 plus 40. So it is almost 160. So that means that the QRS is broader than you normally would find out. Now late potential, because they are late, that means there is some still electrical activity going in the myocardium. And normally late activity means late transmission of electrical impulses. That means there is some scarring or fibrosis in the myocardium. So those in some studies have found that if you have late potentials which are positive, these patients can be this is a test for a marker of cardiac arrest or sudden cardiac death in the cardiac. So normally we have this at our hospital at Hinduja. We have done it for few patients. We have not had their follow-up as such, but then because this test is available, we got it at our hospital with that machine. And we have found that most of these patients who are having cardiomyopathy or infarcted where there is end-stage heart failure, those patients have positive late potentials. That is what we have found.
Yeah, so the therapeutic point of view is that if the late potentials or signal average ECG is positive and if the ejection fraction is low, could be a candidate for putting an AICD in those patients.
Yes. So it's an add-on test because you have already a low ejection fraction, some occasional VPCs, and you want to know whether this patient is having, then you can use it as an add-on additional information just to prognosticate and say whether he will benefit. The guidelines still don't recommend it as a requirement.
As you said,
as an academic exercise.
As you said, that splintered QRS also, like, the scars and, any abrasion, these are the signs of, myocardial fibrosis, old MI, sudden death, arrhythmia. So these are the same significance. Yeah, next, Vaibhav.
Yes, so question from Dr. Jagdish from Mumbai. What is sick sinus syndrome post-COVID? Is it self-limiting or whether there is an indication for pacemaker?
Amaya, you want to answer that?
So we are seeing a lot of arrhythmias post-COVID. Now it is difficult to say whether this is actually due to post-COVID myocarditis or it is just an autoimmune reaction or it is just a new onset sick sinus. If the patient is elderly and has a sick sinus, then we would suspect that this is just a degenerative process which has occurred. But in a younger patient who is in his 30s, 40s or 50s and then develops his post-COVID, then probably it's a post-COVID sequelae. Now, how long will you observe them? Difficult to tell. If the patient is symptomatic, then definitely I would observe them in the hospital and do a 7-day holter and see what is the duration of the pauses, whether these patients have long pauses. Also do a troponin and see whether there is active myocarditis and D-dimer to see whether there is this thrombotic phenomenon, because where microvasculature is there, then probably NOAC would give some benefit. But I have not seen lot of, though arrhythmias are common, atrial fibrillation is common, bradycardias are common, tachycardias, even sinus tachycardia is common, or what is called as postural orthostatic tachycardia syndrome is also common. The indication for pacemaker or the requirement for pacemaker is extremely rare. In fact, most of these myocarditis are post-viral, they always recover. So almost 95% of these patients totally recover and they don't need a pacemaker.
One can do a cardiac MRI also to rule out myocarditis. And then you may know that whether it is degenerative or not.
Correct.
In an elderly patient.
Other thing, Amaya, yesterday only during our midterm ISICON, in fact, our chairing and Dr. Narasimhan was mentioning, this inappropriate sinus tachycardia, it seems, is reasonably common, you know.
Yes.
Post-COVID, it takes few months or maybe more.
Right.
And he was mentioning all these beta blocker, maybe drug like ivabradine, drug like metodine. You know, as you rightly mentioned, he said antibodies to anticholinergic system or things like that. And there are few antibodies which are recommended, but inappropriate sinus tachycardia, because many times this patient comes with a fatigue, like, you know, palpitation, etc. And you see the ECG, the tachycardia. So maybe in the sinus node dysfunction, we can probably include that also. And as you said, and what I showed also, few ECG, AV blocks are also just a sinus bradycardia. And when you see the overall supraventricular tachycardia is supposed to be most common, you know, and ventricular tachycardia a little less. So supraventricular like atrial flutter, fibrillation, then comes probably bradycardia, then all those things. And the last is probably ventricular tachycardia, that way, in that whatever arrhythmia in the COVID time, you know. But many times, as you said, these are the cases which are bad COVID also, and maybe they may succumb due to the bad COVID time. So we don't know the follow-up of these patients truly. You know, even the international in the study circles also, you know, because a few study circle has shown, but there's no definite clear-cut like a prognostic point of view, like using AICD or using this. Only thing that few patients they have done your ablation of ventricular tachycardia, you know, where at the few cases they've done the ablation for a ventricular tachycardia, but where they could find, I think, epicardial focus, and you know they could ablate that. But by and large, as you said, this is possibly due to the infection severity and infection, the grade, and plus the pre-morbid illness like elderly people, men, history of hypertension, already left it enlarged, so LA stretch, etc. You know, yeah. Next, Vaibhav.
Yes. Another question from Dr. Pritesh from Solapur. In patients with hypokalemia, should we calculate QT interval or QU interval?
It's always a QU interval, this one, you know, because that's why I said, you know, if you see in the books and all, they say QT interval, we conventionally say it's a QT interval only, but ideally it is a QU interval, you know, because, you know, the T wave does flat, the T wave does become inverted, but it's basically coming off of U wave and the U wave inversion. So always measure QU. That is my, this is my way of teaching, you know, most of, I don't know, maybe I can sort of, you know, expand on that. But I feel it's a QU interval, you know. It's a QT as such is like it is something like a misnomer. But conventionally we go by QT interval because most of the time there's nothing like a QU interval. It's a QT interval prolongation we talk about. Amaya, you have anything?
Yeah, I agree. The only thing is that clinically what happens is to measure, it becomes difficult because the U wave sometimes is so shallow or so short. So for clinical practice, we normally draw a line from the downslope of the T wave and see where it reaches the baseline. And that is the point where you measure, you know, the end of the interval. And then that you take for the correction of the Q.
Agree, yeah.
Because the U wave is part of the repolarization.
Yeah, it's a part
that
of
is important. So when we are saying QT, we are saying the time of repolarization.
Exactly.
So U is also part of repolarization.
Exactly,
so
yeah.
in that particular sense, it is QU interval.
Exactly. That's in the part of the, it's a repolarization. QU is a part of it. Yeah. Okay. Then.
Yes. So another question from Dr. Manoj Agdale from Ahmednagar. How frequently we should monitor serum electrolytes in case of ACE inhibitors or digoxin or diuretic therapy?
Well, it's a broad question, but so if I were to say, first of all, any RAS inhibitor which you start, you should measure the potassium on the 4th or between 7 days.
Yeah.
Between 4 to 7 days, you should measure it once to know how much it gets elevated. Then it stabilizes by and large unless there is an additional insult. The other thing which we just now actually I forgot to emphasize is when you're using NSAIDs along with these drugs of ACE, ARBs and all, you know, patient is a known antihypertensive, you give him an NSAID, he goes into CKD and he goes into acute kidney injury and the potassium goes haywire. So that also has to be taken into effect. Now coming to Digitalis, you said Digitalis also and diuretics?
Yeah.
So
Yes, yes.
diuretics in the ICU setup at least once daily. If you have established hypokalemia, then 12 hourly. If you have very severe hypokalemia like 1.7 I showed you, you should do 6 hourly correction, 6 hourly correction, 6 hourly till you reach a safe level of 0.5, and then you can do it 12 or for 24 hourly. But as a routine, 24 hourly at least when you are in the ICU for the first 2-3 days. And Digitalis also. So Digitalis, we have serum digoxin levels measurement available. We can do that in the therapeutic range and keep it below 0.10, 0.12 around, and not to go around 0.18 and so on. But half digoxin daily is going to be sufficient enough not to lead to, unless you have hypokalemia. Please ensure that the patient doesn't have hypokalemia on Digitalis, and therefore in olden days a combination of potassium retaining drugs and a diuretic came into being, and now they are widely available, not only with MRAs but also non-MRAs, amyloride, hydrochloride. So these potassium retaining drugs along with diuretic also are available. Or else you can give oral Kesol in the ICU setup, you can give potassium correction and so on.
The other thing, which Vitisha sort of, highlighted during his talk, even the dietary measures also should be looked into in such borderline situation. It is not just, you are doing it and we have to take action. So maybe the dietary source also we have to be a little bit guarded. And again, giving a very simple algorithm is difficult, case by case. Basically, we have to look into the case and take a call. But outdoor practice, as Viti mentioned rightly, initial that period, is very, very important, because many times these like ACE inhibitor, ARNI, Arbs, etc., they do have a tendency to retain, and even the GFR is falling down in the beginning because they remove the efferent arterial vasoconstriction. There's an important, intraglomerular pressure rises, and that takes time for it to, like your entire process, glomerular tubular network also to come into the role. So that initial period we have to take into account. And then once patient stabilizes, even the GFR improves. That is where all these, our drug like a SGLT2 inhibitor, and then your ARNI, etc., in heart failure situation, particularly in a difficult situation. It's all easy to say in a routine, but in difficult situation is always challenging. That is why, in the heart failure treatment, when you're using these drugs, we are now talking about potassium reducing drug like Epetiomar, which is, remove the potassium, because we have to use this drug. At the same time, we have to see that the potassium doesn't go out that way, So use both the drugs, like potassium reducing drugs, and also these heart failure drugs. Next.
Yes, so question from Dr. Jai Prakash Lalwani from Mumbai. It is difficult to do a myocardial biopsy. So what is the best way to determine use of steroids in a given situation of myocarditis? And is there a clinical criteria for steroid use?
That is, again, I didn't touch upon detail because that was not the sort of, we wanted to give overview of myocarditis, and then some ECG was the main thing, It's all depends upon the clinical course, depending upon other multiple, like do you have any autoimmune illness, rheumatoid arthritis, SLE? What is the real etiology of the myocarditis? Depends on that. So like even a SLE myocarditis, one pericarditis, the steroids are really indicated that way. So it all depends upon the situation. Giant cell myocarditis is a bad situation. That's what I mentioned. In 6 months' time, nearly 90% patient abroad go for a heart transplant, which in our country possibly is a little difficult to follow. So this is all depends upon the autoimmune immunological disease, where what type of disease patient carrying, and conventionally our routine run-of-the-mill myocarditis, like all these your Coxsackie or parvo and all these viruses, they are most of the time self-limiting. At the most, they may get into like a persistent heart failure is one situation where steroids, we have given like, long time back, one virus, Kikuchi, Kikuchi is one that we had few cases which precedes with like this myocarditis, and then later presentation typically like a tuberculosis, Then we have done the biopsy. Later, in the course of the disease, gland comes in, and when you've done the biopsy, it turns out to be COX like that. So we started in such patients who are persistent tachycardia, in heart failure. We used Digitalis, just rather a steroid, just to control the the severity of this infection, the myocarditis. So heart failure is one indication, cardiogenic shock is one indication, patient going into dilated heart is one indication, and then like this immune complex disease, or you are talking about autoimmune disease, yes, and then of course giant cell is a bad disease. So this is like it depend again on the case base, I would say.
Regarding the biopsy, I think currently Fortis Hospital, Mulund, and HN Hospital. So HN has a very robust, Reliance Hospital, has a robust heart failure department.
I see.
And in fact, all cardiac transplant patients have to undergo biopsy every 3 monthly in the first year, and after that every yearly. So they have almost done, I think, 120 patients. And in fact, regularly, almost every week, they are doing 2-3 biopsies. So in case there is a need, I think, at least in Bombay, now we have this facility where these patients can be referred to these centers so that the biopsy can be done in case there's a requirement. And they have a proper heart failure specialist who can take care of this condition. And they have treatment like ECMO and, LVADs for these bad patients who can be supported hemodynamically during this acute stage.
Yeah, this all I agree with you. Is absolutely reality of the treatment, I would say, because I remember Dr. Balkrishna, one of the prominent, I think from Chennai, done a lot of transplant even. Of course, now Mumbai is catching up. But, he has shown so many cases in ad-driven and ECMO for months together, pediatric age group, second transplant. I can tell you the type of cases, what they're doing. So these are all the reality today in practice. So we need to, because subspecialty has grown so much. Yeah, absolutely. Yeah, next question, Vaibhav. How many are there?
Hello. Yeah, so 2-3 more questions. Am I audible?
Yeah, you are audible. We'll do another 7-8 minutes.
Okay.
And then we will, wind up,
Okay, fine. So we'll take up the next question.
Yeah.
What is coupling interval and how to interpret it?
That maybe Vetisha can take because of Digitalis toxic coupling interval. Yeah. Time from the misbeats, your voice,
Yeah. No, let Vaibhav take it.
Vaibhav.
Give other examples also. Not Vaibhav, sorry.
Amaya, you can take.
Yeah, so coupling interval is that the VPC. So you have a sinus rhythm, you have a QRS.
Yeah.
After QRS, you have a VPC. So if you measure the interval from the QRS, that native QRS to the VPC, that is called as coupling interval. So that coupling interval, if you have a single foci, if you have a VPC which is coming from the same foci again and again, that coupling interval will be fixed or it won't be changing. If you have varying coupling interval, it means that probably those are multifocal VPCs. So the coupling interval doesn't have a lot of diagnostic value, but if the coupling interval is very short, that is, it is falling on the T wave, the VPC is falling on the T wave, which will cause an R on T and thereby give rise to torsades, which we normally see with ectopics which start from the conduction system, from the Purkinje system. So you have a narrow ectopic, which is his Purkinje ectopic, which is coming very early and falling on the T wave. So we have a very short coupling interval. So in these patients, they are more likely to have torsades, R on T causing torsades or VF. And that's why these patients have syncopal history. So if you see that on Holter, then probably we would treat them with propranolol, which is one of the drug of choice. So coupling interval is from the native QRS to the VPC is called as the coupling interval. So you see whether it is fixed or whether it is varying. The other interval after the VPC is compensatory pause. If you have a pause, because once you have a VPC, you have a pause till the next sinus beat. And this is called as a pause. So it could be either compensatory or non-compensatory. So if it's compensatory, that means the RR interval between the pre and the post VPC is double of the native RR interval. So it gives that it is mostly a VPC coming. And if it is non-compensatory, it's going to be an APC or atrial ectopic coming from the upper chamber.
At this point, Amaya, you can also, since we're talking about Digitalis, Ashman phenomenon also you can explain, because again, based on the VPCs,
so Ashman phenomenon is basically something called as concealed conduction. So you have in atrial fibrillation, you have an atria which is beating at the rate of 600 beats a minute, so which is extremely fast. And there, some of these beats, they enter the AV node and the right bundle, and that's why that conduction is not seen on the ECG, because they enter and they depolarize the AV node and the his bundle, which doesn't cause any deflection on the ECG. And some beats which will conduct after this concealed conduction, you will have a right bundle burst. For example, if you have a 400 beat atrial fibrillation, and then out of that, say 10 beats enter the right bundle and cause it to be depolarized, the 11th beat will again enter the right bundle and have a right bundle branch block morphology. So this is called as Ashman's phenomenon. So you have an intermittent bundle branch block morphology, and this is basically because of concealed conduction, which is not seen on the ECG. And this is called.
So this is not a sign of, this is a normal phenomenon, not a sign of
normal phenomenon. You will normally see with the shorter RR interval, you will see RBVB. With a longer RR interval, you will not see it. So it's almost like a rate-related appearance.
It's a rate-related appearance, but in a atrial fibrillation setting. Yes, okay, Vaibhav, next question.
So another question: why there is a ST depression in AVR with elevated PR in AVR?
Exactly, mirror image. Basically, it's a AVR is, and even the V1 for that matter, particularly AVR is more like, the away from the, all the, electrical forces are going from is going away, not to the leads. It's, AVR is going towards the right hand, what we, like, therefore, what we see in the, like your anterior, all the leads, this will have exactly reciprocal changes like here. So they are like a cavity, this one, cavity is therefore, what we see ST elevation. Similarly, what we see in an infarct ECG, like an inferior wall MI, we see in anterior wall reciprocal changes. So this is something like that, all the thing anterior being a cavity lead, that shows, ST like a depression and the PR segment elevation. Then.
Yes. So is there something called as poor R wave progression in inferior leads?
I don't know about poor R wave. In general, whenever there is a, basically we know R wave is a sign of myocardial muscle, it's a ventricular depolarization. Now, if you have got any cutoff of ventricular depolarization due to, say, infarct or, the muscle, like in acute MI, over time, the scar becomes small and small. In the beginning, you may have a QS pattern. Slowly, small R wave may come up now. And after some months, maybe R wave, only R wave, no Q wave at all. So this we have seen. Smaller the infarct, sometimes the R wave may totally, come up after some time, which also means the myocardium has recovered or whatever, the spontaneous recanalization, etc. Or maybe the normal muscle is more than the abnormal, because abnormal muscle gives Q wave. Normal muscle gives R wave. If you add Q minus, add plus R wave, and that is the summation of the net force. So in inferior lead also, like a R wave is a tiny. This many times we do see in our follow-up ECG of an inferior MI. Say 6 months later, when patient comes in inferior, we will have just like a little tiny R wave. Maybe another year later, he may have totally normal ECG. What do you say, Amaya? So it's a basically mixture of positive and negative forces.
Yes, I agree. So normally, as sir rightly said, R wave will always be there in the inferior leads. And infarcted patients, there is a loss of R wave. There's nothing like progression here, because the R wave in 2-3 wave is almost similar amplitude. So you don't, the largest amplitude may be in lead 2, because that is what is called as the combination of lead 1 and 3. So otherwise, it is the maximum R wave seen in lead 2, comparatively smaller amplitude in lead 3 and AVF. But you will see that the R wave is always present. If you don't see R wave, the reasons for absence of R wave are: one is left axis deviation, where you can have that. You can have a left anterior hemiblock. You can have a Q wave in the inferior leads, inferior infarction. So there are reasons why you may not have a R wave or loss of R wave. So one can think of those DTs.
In fact, in bipolar lead 1, lead 2 is a lead, that's a long lead to everything we take, better P wave, better QRS, voltage, everything.
And
that's
the
why,
other reason possibly is, we have 6 chest leads to reflect the anterolateral wall. Whereas on the inferior wall, we do not have so many leads to represent and then call poor progression.
Correct. Correct. I agree totally. Because, basically poor progression of the ventricular lead we talk about, And as you said, the limb lead bipolar are essentially like, the...
very important to remember that when you say our limb leads, the limb leads basically are taking a ECG in the frontal plane.
Frontal plane, yeah.
As if you are standing. While the
Exactly.
precordial, the leads are taking it in the transverse plane. So this is a plane which is frontal plane and a precordial plane. So both are all the ECGs, the 6 ECG leads are looking from different view, while these precordial leads are looking from a different view. So precordial leads are more closer to the chest, and that's why they will show you more R wave amplitude, and that's why anterior wall, they're just directly over the anterior wall, and that's why the progression will be nice because they're going from septum to lateral. So you will see nice progression of that R wave. Well, inferior leads, it's just together at one place, so that's why you may not see any progression there.
Anything
just inferior.
That is also the reaon, a low voltage when you talk, chest leads and limb leads, there's a different figure, isn't it?
Yes.
We say low voltage for the limb lead, 5 millimeter, 5 millimeter, and the chest leads about
10.
50. How much?
5 and 10.
5 and 10, yeah. That's why, is also the reason why that, amplitude is important. Yeah, Vaibhav, next question.
Yes.
It's almost 5:30, yeah.
Yes. So is calculating QT interval in bundle branch block anything different? And what is the cutoff or is the cutoff of QTC same?
The QTC cutoff is definitely same, but the calculation is different. So instead of QT, you say JT, say from the junction of the LBB. So where the LBBB ends, so you take the J. That is the point you take as the J, and then from there you measure the T. So you don't measure the QRS because the QRS is widened here, and that's why you are getting a slightly higher ratio of the widen. So there is, there's a paper in circulation where they recommended that it is better to take JT interval, that is from the end of the J point, that is from the start of the J point, which is at the end of the QRS, till the T wave, and there you measure the JT interval. But the cutoff remains the same. So
but it is also, Amaya, it may be a little different in RBBB because there's the initial vector and there is a terminal vector, RBBB also same or different?
Same. So cutoff for QTC is the same.
No, I'm not saying measuring.
No,
like
measuring this thing is only for LBBB. So
not for that. Exactly. That's because of the terminal. Yeah.
Yes, because in RBBB the terminal QR is very sharp, and you can.
I know. That's what
the QRS is.
That's what. Yeah. So LBB is a little.
Is the LBB lead 1 and 2 where you cannot make up where the QRS ends.
Yeah.
And that's why they say that you take the JT point.
Yeah, Vaibhav, last question.
Yes, so we can take this last question. Is there a role of oral isoprenaline in COVID myocarditis with severe bradycardia?
I don't know.
Oral or inhaled?
Yeah, I don't.
Oral isoprenaline. Oral isoprenaline. Oral.
Means orsiprenaline like drugs.
Orsiprenaline.
People like a group of drugs.
It is orsiprenaline, not isoprenaline.
Not isoprenaline. It's okay. It's a derivative.
Yeah.
We do give, but these all, as we discussed earlier, we may give for short period and we can see the response and we can make a decision. But that's okay. That's recommended. I agree with you.
More of supportive care.
Yeah, supportive care like that. I agree, Vaibhav. There will be a lot
will increase the rate only from the not for all the patients.
P-wave, I know. It's not a very great. Inferior, your infra-ECG and all VT problem. It's just increasing the atrial rate, sympathetic activity like that. So maybe a little more this. But it's not for the, as you said, conduction system down, where you go to severe HV interval prolong and all those situations. But, 6 sinus, some situation, bradycardia can help a little bit, It's not but it is recommended like that. I agree. I think there will be a lot of questions, I'm sure. A very good thing must come. And I think, with this, who is that, Nazreen or Milan, who want to make a comment from your side? Because we would like to thank 6th session finished. And Nazreen or Milan, who is going to make a comment? We are really
I think everybody is busy at the moment.
Nazreen has come up. Thankful to you all for giving us this opportunity, to do a 6 masterclass sessions. And as I mentioned earlier, we have to make all those take-home points, like either in the book or something like that. Whatever you are in the process, Nazreen, or what is it?
Yes, sir.
working on all the six.
Well, first of all, on behalf of JB Chemical and entire team, I would really like to, appreciate, and we are very thankful and great to be part of Classic Cardio Academy, because while working in a field and interacting with companies, other companies' colleagues too, we personally have seen that this program is not being, copied or replicated by some other company. So this is wonderful platform, and then I'm very sure most of our delegated, they must have got benefited, because through this 6th session we have lot many discussion on not ECG, not in isolation, but various parameter attached to it. So thank you so much, sir. As rightly mentioned by Sheetal madam in our earlier session, very soon, sir, we will be coming up with more interesting things when it comes to further shaping up heart failure therapy management. So we are going to reveal like what best we can do for our delegates very soon. Probably in a month time, we will discuss with our panelists, and definitely we'll come up with something interesting and very useful in their day-to-day practice.
We must thank actually
Thanks,
our special guest, Dr. Amaya Udyavar, because he was really asset for us, because
It was a pleasure.
No, I agree.
Throughout
I
all
know,
the 6
because-
sessions.
Yeah, because all these
Thank you
sessions
so
and
much,
the idea, the conception and all was great, and we could do it because of his support, because he's in one of the tertiary hospital and he's one of our highly accomplished and very well trained, and also in practice he's doing everything what is in our real world. And it is good that he consented to be our guest sort of speaker, and for the last 6 sessions, it was this. Of course, VT
was
is
an
our
absolute
master
honor,
for
sir.
planning. Yeah, and VT is always planning the exact thing, the exact how to make the topic interesting and all, something different. And we really owe a lot to you, JB Chemicals and Pharma. Of course, our relationship is going to continue, and maybe our maybe different type of like this series we will look into, and we will see with in the course of time. Yeah. Thank you, everyone.
Thank you. Thank
Anything
you all.
Milan
Thank you.
Milan,
Thank you so
anything you
much.
want to
Thank
add?
you.
Stay safe and take care. Bye.
Milan
Everyone,
want to
thank
add
you so much.
anything, or Milan is resting? Okay. Okay, Vaibhav, yeah. I shouldn't forget Vaibhav actually. He's very good, good MC actually. Really very nice, and I must really compliment him. And of course, Milan is behind.
Thank you, sir. Thank you.
Yeah, Milan, you want to say anything before we wind up? Because today was a very hard day for us, me and VT, we were in our meeting, and I didn't take lunch also. VT was.
Hats off to you. I mean, the way you manage all these things. I mean, your dedications towards academics and educating the doctors throughout the interior parts of the India. I think it really helps. Thank you so much, sir. Look forward to future associations. Thank you, Dr. VT Shah. Thank you, Dr.
Thank you.
Amaya.
Bye-bye.
Bye-bye.
Thank you, Amaya. Bye, VT. Bye. See you.
Thank you.
Okay.
Good day, everyone. Bye-bye.
Yeah, bye-bye.
Yeah. Thank you so much.
Recording
Yeah.
stopped.
Your